on behalf of INASL, welcome you all to this special session of liver clinics. India, being a spiritual country, we have lots of rituals in our tradition. Liver clinic brought to us by INASL is likewise a ritual for all the budding hepatologists. The spiritual capital of India has its proud privilege in hosting this session of liver clinics. We have amongst us, ladies and gentlemen, an epitome in the field of hepatology, a persona par excellence, and words fall too short to introduce him, Professor Patrick Kamath. The uniqueness of liver clinic lies in the lucid and effective way of case-based discussion of day-to-day clinical problems in hepatology. I am pretty sure that everyone would have a fantastic evening enjoying the discussions. So without any further delay, I would like to invite on stage Professor Dr. Ajay Duseja sir, Professor and Head of Department of Hepatology, PGI Chandigarh, and Secretary General INASL for embarking the commencement of today's session. Thank you, sir.
Thank you, Akash, and good evening, everyone. So on behalf of the Indian National Association for Study of the Liver, INASL, it's my proud privilege today to welcome you this second edition of INASL Clinics by Dr. Patrick Kamath. So I think before we start, let me give you a little background on this, how this originated and how we started this. INASL is a vibrant body, which is an official body of the hepatologists of this country. And the motto or the aim of this society is to promote the discipline of hepatology in this country. So it's relatively younger in comparison to the bigger, I would say, brother gastroenterology society, but we are almost now 40 years old society, and we have more than 1,000 members now. And as I said, the aim is to promote the discipline of hepatology in this country. So Dr. Patrick Kamath, who is our regular faculty in our annual meetings of INASL, so there we always used to have this, a session by him, so-called the liver clinics by Dr. Patrick Kamath, and which used to be loved but so much by, not only by the faculty, delegates, and everybody around, that the people started requesting us that why do you have it only in your annual meeting and why not otherwise? So this is how, the idea came in, and we thought that in addition to the annual meeting of INASL, let's start, this kind of liver clinics, which is a case-based discussion, maybe one more time in any part of the year, and keeping a gap from our annual meeting of around 6 months. The annual meeting of INASL usually is in the month of August. Now coming to, Dr. Kamath, I think those who don't know him, because as I said, he's in US for last many years now, but then he's born and brought up in India. His initial education, MBBS, was from St. John's Medical College, Bangalore in 1976. Then his first year residency medicine was in All India Institute of Medical Sciences, 78, and then in 1980 he did his MD from PGI Chandigarh. After finishing his MD internal medicine from PGI Chandigarh, he did his DM gastroenterology in 1982, again from PGI Chandigarh. Then he moved to Bangalore for a few years, but then finally went on to US, and now he's the in US, if I'm not right, 80, 91. So he's in US now for almost 23 plus 10, maybe around 33 years. And now he's the professor of medicine and chief of gastroenterology and hepatology at Mayo Clinic, Rochester, Minnesota. So before we start the, with the case-based discussions, and you will love, the kind of presentation he does. And my request to all of you would be to, take this opportunity to interact with him as much and ask him as many questions as possible. Don't worry about that, what are you asking this questions. So please keep writing your questions, come to the mic, introduce yourself, keep asking. Let's make it a little more interactive, session. To give him break in between, two of us also will chip in to, make some kind of case discussion. But predominantly, as I said, this is going to be his show. And please ask us questions, keep writing your questions, and at the end, we can have some discussion. So before we do that, as a ritual, we always start our proceedings for any education program with our, taking blessings from Goddess Saraswati. So for that, we will do a simple lamp lighting ceremony, and I'll request Professor Kamath to please come on the stage. I'll also request Professor Chawla to please accompany him. Dr. Rohit Gupta, Professor Dikshit, please come on the dais to come on and do the lamp lighting.
पद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
So I think we'll straightway go on to the academic program, and Dr. Akash, please take over and invite the chairpersons for the first session.
Thank you, sir. We'll be starting our first session, that is on abnormal liver function tests. For the session, I would like to invite upon the dais the respected chairpersons, Dr. Yogesh K. Chawla, sir, ex-director, PGI Chandigarh, ex-professor and head of hepatology, Department of Hepatology, PGI Chandigarh, ex-president INASL, professor of hepatology, Kalinga Institute of Medical Sciences, Bhubaneswar, and Dr. S.K. Shukla, sir, associate professor, Department of Gastroenterology, IMS BHU. So please come on the dais. Thank you very much, sir. Sir, I would request the chairpersons to invite the panelists for the session.
It's my great pleasure to invite the panelist for this session, Dr. Shekhar Puri, who is a consultant gastroenterologist in Varanasi. I think he has not yet arrived. Dr. Santosh Yadav, he is also a consultant gastroenterologist in Varanasi. Dr. VP Abhilash, I think he has also not arrived yet. He is a medical superintendent at ESI Hospital. He is our alumni. And Dr. Nilesh Rai, he is a consultant gastroenterologist and I think an assistant professor at Heritage Institute of Medical Sciences, Varanasi. So I think three of the panelists haven't yet arrived. So anyway, it's my great pleasure to invite Dr. Patrick Kamath to start the session for his illuminating talk and discussion. Thank you.
Thank you so much. Thank you, Ajay, for giving me the opportunity of coming to the holy city of Varanasi. Thank you, Vinod. Always my dream to come to Varanasi. Gave me an opportunity to wear my Varanasi silk shirt. And also this is the birthplace of Ayurveda, so I'm really honored to be here. And Santosh, I'm sorry you're the only panelist, so most of the questions will come to you. Okay. So while I'm presenting the case, please pray that the other panelists come quickly so you won't get so many questions. Okay. So any DM students here? Can you put your hand up? No DMs? MD students? Okay. So that section, I know I can ask questions. Do you want to come up? There's a lot of place here. We can have a better interaction. If you don't feel shy, don't worry. You can come up here, Bill. Because this is for you. These cases are mainly for residents and fellows. Okay. So, for those who don't know, this is a protocol for the session. I'll present a case. Then I'll ask you, show of hands, what you would do. I'll give you some choices. Then we'll have comments. I said discussants, but Santosh, maybe some comments from you. And then I'll go over teaching points from the case, okay? So before we go to the case, just practice. So this is how we'll go. The question is second highest, not highest, second highest. Strike rate in the World Cup. Who thinks it's Glenn Maxwell? Anyone? Cricket fans? Klaassen? Rohit Sharma? No one? Markram, anyone knows? Mendes? Santosh? No guess. Okay, so this is the strike rate. Okay, this is how we're going to go about it. We'll have the panel discuss and then I'll try and give you some answers. There's never an absolutely right answer. I'll tell you generally what I did. Okay, let's start. 61-year-old, 1 week jaundice, light colored stool, dark urine. For MD students, whatever is in blue is important for you. Pruritus, fatigue, fever, no chills. Dull, right upper quadrant pain and nausea, no vomiting. So when you get a picture like this, what is the type of jaundice that you have? Extrahepatic cholestasis, anyone? Intrahepatic cholestasis, this is, remember, dull right upper quadrant pain. Intrahepatic cholestasis, okay, equal number. Hemolytic, no one. Hepatocellular, one. Mixed hepatocellular, cholestatic, okay. Santosh?
Extrahepatic.
Okay. And why did you say extrahepatic?
Sir, to rule out any biliary obstruction, because there is a history of jaundice, right upper quadrant pain, pruritus, and fever.
So, features of cholestasis are deep jaundice, light colored stool, dark urine, pruritus are all features of cholestasis. To make it extrahepatic, we say colic, cholangitis, and on examination, a palpable gallbladder. So those are the three features of extrahepatic. Biliary colic is very typical. So again, for MD students, always ask when they get the pain, how long did it take to reach maximum intensity? Biliary colic reaches maximum intensity in minutes. Okay, in minutes. It doesn't take long time. So it doesn't last the whole day. It reaches peak in minutes. Only 4 causes of pain which reach peak in minutes. Santosh, do you want to think of pain which reached peak in minutes. You know, they say I was fine, and then they're rolling over in pain.
Sir, choledocholithiasis,
Good. So stones. So biliary colic.
biliary
One.
colic.
Anything else? So we're looking for 4 causes. So the other causes are a perforation. You know, perforation is typically very severe pain suddenly, embolic, not thrombotic, embolic episodes, and hemorrhage into tumors. A tumor suddenly increases in size. Those are the causes of very severe pain. So this is not like that. Okay, let's go. Oh yeah, okay. So as with pain in the epigastrium, reasonable, yeah. And remember, MD students, my rule for my fellows is when the patient gives the complaint, there should be not more than 5 possibilities. At the end of the history, you should be down to 2 or 3 possibilities. If you have more than that, your history is not good enough. So we can get really a lot on history. So, who thinks this is viral hepatitis? Can this be viral hepatitis? Okay. Drug-induced? No one? Possible. Choledocholithiasis, some pancreatic cancer, lymphoma. Yeah, so these are all possibilities in here. Okay, we'll come into that a little later. So what do you want to do next, Santosh?
Sir, ultrasound abdomen,
Do you want to take a history? You know, typically they give them the complaint, now we have to try and find out more. We want to know if they're on any drugs. We want to know exposure.
yes, sir, any history of any drug or alternative medicines.
So I'm giving you history. Hypertension, hyperlipidemia, never drinks. This is a picture which you can also get with alcohol. No alcohol, no history of liver disease before. Amlodipine and carvedilol, esomeprazole. 6 weeks before jaundice, hospitalized with COVID. Glucocorticoids, meropenem, ceftriaxone, and doxycycline. But everything discontinued when the patient was discharged. So no drugs for more than 4 weeks now.
Yes,
And when he left the hospital, AST and ALT were normal. So he was completely asymptomatic and well from discharge. And this was a time of when half the people were getting COVID. So 4 weeks later, he presents with this history. So based on this, what do you think now? Which of these possibilities? So we are trying to reduce it. So we said the pain is not typical of biliary colic. So it's a steady pain, persisting. So unlikely to be stones. But the others are still possibilities here, okay? So now we examine the patient. Patient is jaundiced, and these are the blood tests. Bilirubin 3.5 direct, 2.9. So we're talking about 80% direct. ALT 495, more than 10 times elevated. Alkaline phosphatase about 2.5 times elevated. Serologies for ABCE negative, smooth muscle panel negative, CBC is normal. Okay, so this is what we have now. So questions for MDs. Normally, so for you and me, hoping we're okay, is our bilirubin, if you're completely asymptomatic, normal person, is it 95% conjugated, anyone? 80% conjugated? Conjugated, okay? 95% unconjugated, anyone? Come, someone put their hand up. No one? 80% conjugated? Unconjugated, okay. So most think it's, remember most of our bilirubin is unconjugated, but I'll come into that again. So when do you say conjugated hyperbilirubinemia? 90% conjugated? 75%? 50? 20? Good, very good. So remember, normal bilirubin is predominantly unconjugated. So breakdown of red cells coming to the liver. Once it's conjugated in the liver, it's very rapidly excreted. okay? The problem was with the older way of testing, so it's predominantly unconjugated. So when we say less than 5% is conjugated, conjugated hyperbilirubinemia is when it's more than 20%. When I did my DM, it was 50%, but it's 20%, okay? So you're right. Okay, so this patient has conjugated hyperbilirubinemia. Hepatitis serologies are negative. So how do we interpret this now? Is this hepatocellular? Is it cholestatic? Is it mixed? Because the type of condition depends on these three. What do you think, Santosh?
Sir, it is mixed.
Good. So we look at the R value. So anytime you have AST, ALT, and alkaline phosphatase elevated, look at the R value. What is the R value? Look how high the ALT is, look how high the alkaline phosphatase is, and calculate. So R value more than 5 is hepatocellular. So alkaline phosphatase usually not much elevated, AST and ALT greatly elevated. 2 to 5, mixed pattern, less than 2, cholestatic. So this person is a mixed pattern. So here is your approach to elevated alkaline phosphatase. Rule out physiological causes. Pregnancy, it goes up. Remember, blood type A, fasting and postprandial alkaline phosphatase is the same. But if you're blood type O or B, after eating, intestinal alkaline phosphatase goes up. So always check alkaline phosphatase fasting, not postprandial. Once alkaline phosphatase is elevated, you want to know whether this is bone or is this from the liver. So you do the GGT. If the GGT is normal, this is from the bone. Look for other disease, osteomalacia should be common here. If the GGT is increased, that is of hepatobiliary origin. So MDs, clear? Hands up if clear? Okay. Once it's elevated, then you do a right upper quadrant ultrasound. If the bile ducts are dilated, MRCP or an ERCP. If they're not dilated, you can check AMA, depending on how common it is, and then you decide. AMA positive, ultrasound normal, or AMA negative, you want to do a liver biopsy. AMA is negative, ultrasound normal, alkaline phosphatase elevated, look for symptoms, look how high the alkaline phosphatase is. If they're more than 50% elevated or if they're symptomatic, this should be symptomatic, liver biopsy, MRCP or ERCP in these patients. If less than 50% elevated and they're asymptomatic, just follow the alkaline phosphatase, okay? Now patient is jaundiced. Remember we talked about different types of jaundice. If it's indirect hyperbilirubinemia, what are the two possibilities? Only two possibilities.
Sir, hemolytic anemia and Gilbert syndrome.
Very good. So it is hemolysis or Gilbert's. So if there is anemia with hyperbilirubinemia, it is hemolytic. If there's no anemia, it's Gilbert syndrome. And then for MDs, it's very easy. Once you get hemolytic anemia, can one of you tell me what are the cause of hemolytic anemia? 3 groups. MDs. The red cell has only 3 components. It has no nucleus. So it has a membrane. So membrane disorders, spherocytosis and all will call hemolysis. It's got hemoglobin, so hemoglobinopathies, sickle cell disease. And then it has got oxidative pathway, so you typically phosphorylation depends. So it's very easy to evaluate hemolytic anemia. Direct hyperbilirubinemia. Then you look at the R value. More than 5, hepatocellular. We're talking about viral hepatitis, drug-induced autoimmune. 2 to 5 is mixed, so this is our patient. So it can be with alcohol, late stages of viral hepatitis, drug-induced autoimmune hepatitis, later stages. Less than 2 R is cholestasis. So this is long-standing biliary obstruction or infiltrative diseases of the liver. Okay, so this should be your workup for alkaline phosphatase and jaundice. So we'll come back to our patient. So this patient's R value is 4. So what I'm trying to go over is no matter how complicated a case is, if you go about it very systematically, you can get a diagnosis. So this is R value 4, direct hyperbilirubinemia. Now, Santosh. Sorry, you're the only one for questions.
Sir, इसमें AMA has been not done.
Which one?
It has been done, it's negative.
All negative.
Okay, sir. Then next will be,
So elevated alkaline phosphatase. Next, what will we do?
sir, granulomatous liver diseases to rule out sarcoidosis, tuberculosis in our scenario.
What test do you want to do next?
Sir,
Do you want any imaging?
yes, sir.
Yeah, good.
MRC.
So we'll get an ultrasound. So typically we will get an ultrasound, it's the cheapest. So we see normal, the gallbladder wall is 3 millimeters. Here it is 14 millimeters, okay? But no tenderness, no biliary dilatation. So is this acalculous cholecystitis? So especially physicians know that when a patient is in hospital, has not come with liver disease, come for something else, has been hospital for a long time and is very sick, if they get pain, fever and elevated liver tests, think of acalculous cholecystitis, okay? So hospitalized patient, critically ill, unexplained jaundice, fever or right upper quadrant pain, must get an ultrasound. And the ultrasound shows you thickened gallbladder wall, fluid, and a positive Murphy sign. So this is not acalculous cholecystitis because the patient did not have pain and no fluid in there. So we've ruled out viral hepatitis, no drugs for 4 weeks. So we've ruled out drug-induced liver injury. We've ruled out stone. We're left with lymphoma. Are you happy with the diagnosis, Santosh, lymphoma? Or you're not so happy? You think maybe something else is
Sir,
happening?
there is no abdominal lymph node.
Very good. So nothing else in imaging suggests
Sir, and
lymphoma.
second, he was having COVID also. It could be a sequel of
Very
COVID
good.
hepatitis.
So what are you thinking of?
Sir, COVID-induced hepatitis, he may,
So usually, no, I agree. This could be
either he
related
was
to-
given any remdesivir type of medicines or not in that period, or any antiviral drugs for COVID. That can also cause.
Yeah, no, I agree. So the drug, this is 4 weeks later. So his liver tests were normal.
Yes, sir.
And then COVID, where they get very sick, the cholestatic, usually follows the COVID. Here for 4 weeks, the patient is normal. So what are you thinking of here? You're on the right track, but what are you thinking of?
Sir, it could be COVID-induced hepatitis or any.
So that is typically during the COVID-induced hepatitis. Here I told you for 4 weeks he was okay, but we'll come into that. So what do you want to do next? So the question is undiagnosed jaundice and liver tests. When you finish doing all your tests and they're negative and it continues, what is the test you should do? Anyone? Eventually, but before that, do you want to do any test? Which one? That will tell you whether there's tumor. We don't find any tumor on imaging. What did you say? Someone said it. But there's nothing for dilatation here. It won't. And my fellows, there's a rule for my fellows. Any extra test, they have to pay for it. Patient shouldn't pay for it. You know, we have to do only what's good for the patient. So the patient came to us. This is now when the patient is referred to us. Jaundice has got worse. fevers 39, facial and lip swelling. We can see that on examining the patient. Neutrophil count is decreasing. SARS-CoV-2 negative, creatinine 1.3. Ultrasound, again, spleen normal, but the liver is getting big. Gallbladder wall thickening and nothing else. What's the test you will do now? Before the biopsy, you want to know what you're likely to get. What you're looking for on the liver biopsy. Which one? And if tuberculosis is negative, what will you do? So your biopsy should be mainly to confirm your diagnosis. It's an invasive procedure. So you must have narrowed things down a lot before the biopsy. Which one?
Serum H level, sarcoidosis.
Okay, you're thinking sarcoidosis here. Is that what you're thinking, infiltrative? Reasonable. Is raised twice. So you're thinking sarcoid. But no other lymph nodes. So this is primary sarcoid of the liver, you think. It's possible. I'm not saying it's not possible. Remember the rule. Everything looks normal. You don't have a diagnosis, check ferritin. Okay? Ferritin 2200, CRP, which is like ACE level, very elevated, D-dimers elevated. What are you thinking of now? Very good. So we're thinking of some, you can call it macrophage activity, but we're thinking of some cytokine storm, right? Okay. And due to what? Very good. Due to what? Very good. So before that, good for you. You're doing your DM, right? Guest of honor. We'll ask you a lot of questions. Do you want to come up? Maybe if next. No, I'm serious. It's because this is learning for you. When you get a ferritin greater than 1,000, what are you thinking of? What are your possibilities? It's very limited. So that's how it's a good test to do. You can sit, don't worry. HLH, good. What else? Medicine, MD students with joint disease. Very good, Still disease, because you judge activity of Still's disease with a ferritin. So good marker for how to taper off treatment. So HLH, Still disease, what else? Iron overload, any hemochromatosis, okay? Anything else? Remember in viral hepatitis, as the AST, ALT go up, the ferritin goes up. But typically when AST and ALT come down, the ferritin comes down. But so in the early phases, the ferritin can be in the 1,000 range too with viral hepatitis, okay? Hematological malignancies will give you that. Adult onset Still's disease and HLH. So your differential diagnosis is very small here. So which one of these do you think the patient has now? Very likely. So how do you confirm the diagnosis? And if they're negative, will you rule out hemophagocytosis? No, so you need other information. Remember I said biopsy is towards the end you want it. Anything else that you do? Very good. Okay, so we'll go. So eventually, I'll show you the test results. Liver biopsy looked like hemophagocytosis, and you have to do the other tests for HLH. And I won't go over the details. This is something you need to know, and then you come up with a score. Liver and bone marrow biopsy showed typical changes of HLH. You can see. Okay, let me try here, but you can see the yellow arrow. So this is macrophage, macrophages here, red cells eaten here, apoptotic bodies, cholestasis. So this is typical features of HLH. So there are criteria. You have to fulfill 5 of 8 criteria. So in blue is what our patient had. So splenomegaly, ferritin, hypertriglyceridemia, hemophagocytosis, NK activity, and soluble CD25. But when you have such a difficult patient, even if you don't fulfill all criteria, I think it's worthwhile treating as HLH because there's nothing else you can do here. So this is what happens. So Santosh, you were right, this is related to COVID-19. So the reason why you get this inflammatory syndrome and other viruses can also cause HLH is because there's immune activation and you clear the virus. But with the immune activation, it doesn't stop. So you get the cytokine storm and you get hyperinflammatory syndromes. So typically HLH comes on early, about 2 weeks after the COVID is gone, HLH comes on, about 2 weeks, but it can come on even later, as late as 12 weeks. Usually coming on later is the multisystem inflammatory syndrome. And these are the features. They both have fever and constitutional symptoms. Neurological, conjunctivitis, nausea, vomiting, pericarditis, thrombosis, and kidney injury are features of multisystem inflammatory syndrome. Rash, ARDS, hemophagocytosis, and features of inflammation, these are part of HLH. So, treated patient with steroids, post-COVID, has anyone seen post-COVID? Yogesh, have you seen post-COVID? Have you seen post-COVID HLH? Has anyone seen that? This is different from other HLHs. You know, HLH, which is post-viral, 3-4 months you can stop immunosuppressant. With post-COVID HLH, it goes on for a very long time. So almost 18 months we had to treat this patient. Developed steroid-related diabetes, but eventually has been doing well, okay? So take-home messages. This is messages for all of you in practice too. Any undiagnosed jaundice, especially if you have fever, cytopenia, and splenomegaly, think of HLH. Then do the test for your criteria. Check inflammatory markers. Ferritin is good, so the good next step is ferritin. HLH is a complication of viral, hematological, and autoimmune diseases, and steroids are beneficial in these patients. And your homework for MD and DM, you have to look at HLH management. There are different treatments. Liver in hematological disease, because the liver gets involved, and post-bone marrow transplant liver disease. And one thing about the liver biopsy is, A, you can miss hemophagocytosis. B, when you get hemophagocytosis on liver biopsy, it doesn't mean they have the HLH, don't have the whole syndrome. They have to have other markers too. That's the reason, try and get everything else done before your liver biopsy, okay? Thank you. Questions now. Yogesh, do you want to make any comment? Any comments on the case? Your approach to something which you can tell them, because you see more cases locally. Is there anything else you'd have done? Any other conditions you see which present like this undiagnosed, other than what I've said?
Yeah, once you have done the routine viral markers, one should always look at the non-hepatotrochic viruses like HSV, CMV, Epstein-Barr, and you do get these cases once in a while. HLH is an increasing problem, and at the Institute we've seen some fulminant hepatic failures or acute liver failure also occurring with HLH with hepatomegaly and encephalopathy. So, or blank, think of HLH as a possibility.
I mean, that's your take-home message. And you know, there is malaria causes liver disease. Last week's NEJM, I think all of you would have easily diagnosed it, which was difficult for them to diagnose, but it was malaria causing jaundice and liver test. You can get it with dengue fever. So typhoid can give rise to liver tests. Oh, it's decreasing here, is it? Is decreasing? Oh, is increasing, yeah. So that means you have to be careful because dengue can also go severe thrombocytopenia and cause liver failure too.
No, I think just very nice case. So just wanted to add on this the same thing which you're continuing. I mean, we do see other than the acute viral hepatitis, which is so common, the most common cause for us in the acute hepatitic illness or a drug-induced liver injury. Increasingly we are seeing the tropical infections causing acute hepatitic illnesses to the extent going into acute liver failure. And in that, we always do what we call the lambdas workup, the leptospira, enteric, malaria, dengue, and scrub. So when these patients, the distinction is that after the onset of jaundice, typically in viral hepatitis, this is for the physicians that the fever would subside, but in tropical illnesses, the fever may continue. So we think of a tropical illness, but then there is this close differential of HLH. So if there's a fever and jaundice going on, think of, yes, tropical illnesses in our setup, but also think of HLH, get the ferritin, as you rightly said, and then I think it goes on.
And Ajay, so maybe for the, is there anything in the presentation of these patients that make you think of tropical diseases?
Yes. So 3-4 things which we always say, we earlier, typically in acute liver failure, we used to earlier call them as ALF mimickers, which means they will also come with fever, altered sensorium. So that's the definition of acute liver failure. But then typically when you look at, as I said, the fever would persist in these patients beyond the prodrome, that's number one. When you palpate the abdomen, the liver is bigger. In ALF, we find a smaller liver. And when you do the INR, it may not be that bad, and they may not have signs of cerebral edema. So these are 4 or 5 features which typically helps us, in differentiating whether it's an ALF mimicker or a true ALF because of acute viral hepatitis.
Anything more? Okay. Okay. Thank you so much. Thank you. Vinod, if you don't mind, can you use the mic? The people at the back cannot hear you.
Can I have the question?
I think Vinod has a... Okay, go ahead.
In this country, most of the patients during COVID were treated with very heavy dose of corticosteroid. So do you think using steroid for longer time would have modified the natural course of the disease?
So the question that being asked is, when people are treated steroids, if you gave them for longer, would it have helped you? This is not a common condition. This is uncommon. And so we don't know. All we know is the patients who had this problem, the initial COVID seemed uncomplicated. And so for uncomplicated COVID, there's no indication for steroids. So something happens. So the virus is being cleared. The problem is this cytokine storm. There is a clearing it, but not stopping the immune reaction. And not only is the immune reaction not stopping, it is increasing. So like you point out, so that's the activation is not stopping.
Yeah, because that was the time when the D-dimer is high.
Correct.
Ferritin is high.
Exactly.
Most of these patients have received heavy dose of steroid. So probably this could have changed the scenario, and that's why we may not be seeing so many patients otherwise.
No, I think you're absolutely right. I think many of the cases of what we called severe COVID or prolonged COVID were actually this condition and steroids. You're absolutely right.
Thank
I agree. Dr. Dixit?
What I want to say actually, sir, we have observed commonly, we had a dengue fever last 2-3 months, there was an epidemic almost. And people used to come, so hepatic manifestation is not uncommon, but they are not having clinically jaundice actually. But once you see their transaminases, they will be very high, in 1,000, 12,000, 1,200, something like that. And we have excluded all the common causes. So what I mean to say is this is little manifestation, late manifestation, the patient coming with the transaminase, and it persists for a few weeks actually. And you have ruled out all the other causes, then slowly they will come down. So this is also an observation, not that they will have the jaundice, but when they come with the report, they will have transaminitis, which is relatively more higher on the side. Like for example, patient has got fatty liver disease, and they may have elevated SGPT, SGT because of the NASH. But they will not have the thousands or 800, something like that. But these patients, when you take history, you had any dengue fever, they will say, yes, 4 weeks earlier we had dengue fever. So this is another thing I want to bring to your notice.
Okay, thank you.
Thank you, sir. I think we'd end the session. Thank you, sir. Thank you, respected chairpersons and panelists, and Professor Patrick Kamath, sir. Now, moving ahead for the second case of the day. The second case being a non-alcoholic fatty liver disease or MASLD, and I would like to invite the chairpersons for the session. Professor Dr. V.K. Dikshit, sir, Professor and ex-Head of Department of Gastroenterology, IMS BHU, former President INASL, former President SGEI, and Dr. Rohit Gupta, sir, Senior Consultant Gastroenterologist for Foundation of Research and Education in Gastroenterology and Endoscopy, Prayagraj. I would request both the chairpersons to call upon the dais the panelists for the session and invite the speaker for the session.
I would invite Dr. Anish Dudseja. I think he is one of the leading hepatologists of our country, and presently he is the Secretary General of the Indian National Association of the Study for the Liver Disease. He is a professor head of PGI Chandigarh of Department of Hepatology, and his basic work, NFLD, actually was appreciated. He has done a lot of publication on NFLD, which is one of his favorite subject. And I would also request to come on dais Ravikant Thakur. He is a consultant gastroenterologist of Apex Hospital, Varanasi. He has been one of our alumni. Dr. Vineet Mishra, he is a consultant gastroenterologist, Heritage Hospital, Varanasi. He has done his DM from CMC Vellore. Dr. Indresh Dikshit, who is a consultant gastroenterologist working in Varanasi. He has been one of our alumni. And Dr. VP Singh, he is a consultant physician, medicine. Dr. VP, in Varanasi. Please join. Yes, you start, sir.
Thank you. So I think, as I said, we'll make it more interactive, and just for the faculty, I think we're saving on time for the mementos and all that stuff, and I will request everybody to please stay back in the hall. We'll have the memento giving ceremony at the end of all these sessions. Okay, so before I go into the case discussion, as I said, I'll not be discussing mainly on the diagnostics. Today, I'll be focusing only on the management of a very common disease, the fatty liver disease, or what we call the steatotic liver disease. So before that, again, I will also look at or start, the asking some questions to the house. So my first question to the audience would be, how many of you are vaccinated for hepatitis B? Raise your hands. Good, everybody, almost everybody. How many of you are immunized for hepatitis B? So this is to know what is the difference. Have you ever checked your anti-HPS titers? How many of you have checked your anti-HPS titers? Yes, must check. Very few of you have checked it. As healthcare professionals, I think at least once we must check our anti-HPS titers. Should be documented as more than 10. Never next time if you have a needle prick or any exposure, I think we should know that what is our anti-HPS titer. Okay, how many of you, the males or gentlemen, have waist circumference more than 90 centimeter or 34 inches? That's the definition of central obesity for males in India. Okay, how many of you have ladies more than 80 centimeter waist? That's the definition of, central obesity for, females in India. So with this, my last question, DM residents, if they are there, what is the full form of MASLD, which I have written, Management Decisions in MASLD? What is the full form, DM resident, MD resident?
So metabolic associated steatotic liver disease. Metabolism associated steatotic liver disease.
So it is metabolic dysfunction associated steatotic liver disease. Good, Akash, good. So, this is the new name for NAFLD or non-alcoholic fatty liver disease. And today my job in next 30 minutes is first is to make you apprise of this new terminology, which has come in NAFLD, which we used to call it as a NASH. And then I will also discuss few things about the management issues in fatty liver disease, because it's such a common, this thing, at least in Chandigarh, every second person has fatty liver. And in India, the meta-analysis shows that around 40% is the prevalence, which means again, every second or third person actually has fatty liver disease. Okay, let me start with this case. 51 years old male, non-smoker, diabetic, hypertensive for 10 years. Average body weight in last, 10 years is around 90 to 95 kgs. He also takes alcohol, 2 to 3 small drinks every day in the evening, which comes to around, we know that one small drink is around 10 gram, right? So 30 grams per day. So that makes into 7, if you do it, it becomes 210 grams per week. So his ultrasound was done for dyspepsia. So he was found to have large liver and severe steatosis. Rest everything was normal. So on examination, as I said, his weight was around 90 kg, BMI of 31.9. So for Indians, the cutoff is 23. 23 to 25 is overweight. More than 25 becomes obesity for us. Waist circumference, as I said, cutoff is 90 centimeter for males, 80 centimeter for females, 110 becomes centrally obese. And as I said, he was diabetic, he was hypertensive. So he was worked up. His platelets, lower limit of the normal 150,000. So just be there. Rest of the things were normal. But if you look at his liver biochemistry, AST, ALT were minimally elevated. We still follow an upper limit of 40 international units. So 58, 50 and 48. But AST slightly more than ALT. That was, slightly thing which was happening in this patient. His sugar was normal, but as I said, he was on OHAs for that. But his triglycerides were elevated. The cutoff for triglyceride is 150 milligram per deciliter. His was, 270. And cutoff for HDL, which is a protective, lipid, his was 35. And cutoff for males is 40 mg. It should be more than 40. And for females, it is 50. It should be more than 50. So his was low HDL. So which means that he had kind of full-blown metabolic syndrome, what we call typical, all 5 features: centrally obese, diabetic, hypertensive, high triglyceride, low HDL. This is what the ATP3 criteria, as physicians, are the 5 features of metabolic. So he had all those 5 features, but he had come to us with elevated liver enzymes, fat in the liver. So he was worked up for other things. His viral markers were negative, and ultrasound, as I said, was, showed only fatty liver. So the first question is, in this kind of scenario, in today's definition and today's whatever information we have, what diagnosis will you give it? So maybe we can start with Dr. K.T.
Hello.
I've written the short forms, please don't mind that.
No, considering there is steatosis on ultrasonography report, patient is having cardiometabolic risk factor in the form of obesity, diabetes, hypertension, and increased waist circumference, and dyslipidemia in the form of hypertriglyceridemia with alcohol intake that is less than approximately 20 to 30 ml per day. So patient fits in the criteria of metabolic dysfunction associated steatotic liver disease, MASL.
So MASL D, definitely yes, because the definition is, this is the, as I said, now there's a multi-society Delphi consensus actually came last year. And now the terminology, please remember this, now this is MASL D and MASH, not NAFL D and NASH. So this is the first thing, right? So now what is it? So this is the, diagram which as residents, fellows, I think you should be knowing.
So, Doctor, sorry to interrupt.
Yes, please.
Is NAFL NASH out, or still is it still there are two groups?
So I would say it's still in the transition, right? ASLD, EASL, and LA, and as INASL we have also adopted as MASL D and MASH. Yes. Few societies have not done it yet, but they are in the transition phase. But then, hepatology, the paper, the journal of ASLD is no more accepting papers which writes NAFLD.
Okay.
Journal of Hepatology, which is a journal of INASL, is not accepting papers if you write NAFLD. So you have to write MESL-D and there. So this is what is happening. In INASL, in liver in India, we have also accepted it as MESL-D and MASH. But as I said, few societies are still in transition. Okay.
Thank you.
So this is, the bigger umbrella you should know. The bigger term is now steatotic liver disease, SLD. Within that, you have this metabolic dysfunction associated, steatotic liver disease. And the definition is very simple. You need to have fat in the liver, demonstrated maybe on imaging or any modality. And you should have one out of that 5 metabolic syndrome components. So if you have any one component with fat in the liver, you become MESL-D. But in real life practice, and like this patient, why this all change in terminology and why this all was done, I think let's not get into that. But one of the reasons was that in real life practice like this patient, many of these patients, in addition to having metabolic dysfunction, would also take some amount of alcohol, or may also be hepatitis B positive, may also be hepatitis C positive, but also has metabolic dysfunction, but also has fatty liver. So what do you call them? So that was the problem which was happening. So in this space, what they have done is they have come out with a new terminology, and that is known as MET-ALD. MET-ALD is what? Metabolic dysfunction and alcohol-associated liver disease. So it's a combination of the two. Earlier we had even come out with the terminology like BASH. BASH was both alcohol and non-alcoholic steatohepatitis. So when you have metabolic dysfunction, you also have alcohol. But what they have done is, they have given the limit for this alcohol. So for females, it is 20 grams per day to 50 grams per day. And for males, it is 30 grams per day to 60 grams per day. If somebody is taking that much of amount of alcohol and also has metabolic dysfunction, they can fit into MET-ALD. But if somebody is taking more alcohol, more than 60 grams per day for a male, then they are calling it as alcohol-associated liver disease. Then the alcohol takes over. So you have a disease which is pure metabolic dysfunction driven. You have a disease which is a combination of the two, which means MET-ALD. But then you also have a disease where alcohol totally takes over, that becomes alcohol-associated liver disease. So our patient is taking 30 grams per day, if you look at this, which becomes, as I said, 210 grams per week. So he has now a MET-ALD, which means metabolic dysfunction and alcohol-associated liver disease, a combination of the two. But within that, now they say that somebody who's taking a lesser amount of alcohol becomes what they call the mast cell predominant, and then you can have the alcohol predominant also. I think let's not get into that. Just remember, metabolic dysfunction, this is it. If you have fat in the liver, just look at whether somebody has, the criteria, which I said 5 out of these, even 1 out of these 5 criteria is good enough. You have to call them as, and then you have fatty liver being seen on any imaging. So that becomes mast cell. So if you have any one of these, and if you have fatty liver, you become mast cell. But the next thing you have to see is there any associated other etiology which is contributing? And these are the various other causes of, fat in the liver. This could be, alcohol, as I said, hepatitis C we know causes, all this Wilson's, alpha-1, drug-induced, they all cause fat in the liver. So then it becomes a mix of the two. So in this patient, we had metabolic dysfunction in alcohol, which is combining, so it becomes MET-ALD. So, this is what? So you can have a combination. So now, earlier, non-alcoholic fatty liver disease was a disease of exclusion, which means you had to exclude alcohol, you had to exclude all other causes before you label somebody as NAFLD. Today, the mast cell disease is now becoming a disease of inclusion or affirmation rather than. So if you have just fatty liver, and if you have metabolic dysfunction, you become mast cell D. Then whether there is something else which is contributing, I think that's there. Okay, I think from the, this definition and all, let's move on to that once you have a patient with mast cell D, like this, and which is mast cell D predominant, little bit of alcohol. Now, how do we further evaluate these patients? So maybe
So we are dealing with MSLD, specifically MET-ALD. We have all tests were done. Now we want to evaluate what are the what are the stage of the this MSLD. So we want to know this part of steatosis, inflammation, and fibrosis. For that, you want to evaluate if like we have for steatosis, we want to go for and fibrosis, we want to go for a non-invasive test. Like practically we can do in our clinical practice FIB4, and then a fibroscan, a vibration control transient elastography next.
Absolutely. I think we have a brilliant panelists here with us. So I think the simple, all fatty liver are not same. I think that and see which stage. Somebody may have just fat in the liver, and we used to call them as only NAFL. But once they start developing, inflammation and fibrosis, that is the time when we used to call them as NASH. And then some of these patients can get into cirrhosis, liver cancer. So, just looking at ultrasound showing you fatty liver, it may not be possible for you to stratify them. So you need some testing. Unfortunately, we do not have good tests to look at this NASH inflammation thing. Fibrosis we have good tests, inflammation we don't have, and steatosis we have good tests. So, because the inflammatory markers, histological markers in NASH are little difficult, lobular inflammation, ballooning, which may not be picked up, non-invasively. So we don't have good tests, but we have good tests for steatosis, we have good tests for fibrosis. So this is what we can evaluate in these patients. So as he rightly said, but
Dr.
before
Ajay,
that, yes.
Sorry, very sorry for disturbing you again. When you made a diagnosis of MAFLD, when do you decide that you need to do the etiological workup, other etiological workup? Because in MASLD, you don't need, the definition is, you don't need to have HIV or any other cause of disease.
No, so absolutely. So if you have on imaging, as I said, if you have on imaging fat in the liver, and if you have any of these metabolic dysfunction, your diagnosis of MASLD is made.
So when do you do this?
When do you do this? Again, it's a very important question. Typically, in our clinic, we tend to rule out all other secondary causes if somebody has elevated liver enzymes, because you can have fat in the liver, you can have metabolic dysfunction, but your elevation in liver enzymes could be happening because of something else. Which means just fat in the liver may not be enough to produce inflammation in the liver. So I think typically just message for the physicians would be, if you have not elevated liver enzymes, please go ahead and do all the viral markers. And typically, as I said, hepatitis C is notorious in causing fat in the liver also. So hepatitis C we will always do, but with hepatitis C we will always do an hepatitis B. If there is a young female who has another autoimmune disease, enzyme elevation, even if there is fat in the liver, please do autoimmune markers in that. So clinical context is also important. Similarly, if there's a young male who's there, again fat in the liver, elevated enzymes, we also tend to do ceruloplasmin in them. So copper overload, right? Somebody who's more than 45 years of age, has diabetes, we also do iron profile in them. So clinical context is important, but viral markers in everybody, and maybe autoimmune markers in a given context. But you can also do, as I said, ceruloplasmin and iron profile in a given clinical
What
context.
I gathered was that if he goes to the physician, then it is MASLD and he works up for that. But if he goes to a gastroenterologist,
Question is, when should the patient be referred to a gastroenterologist? This is what we are trying to discuss today, right? So all patients obviously may not require attention from a gastroenterologist, right? So, before you do this APRI and FIB4, which he said, and we will come look at some of the clinical predictors of having a severe kind of fatty liver disease. As I said, all fatty liver disease are not same. So as your age advances, your risk of having NASH or severe fatty liver disease, inflammation, fibrosis goes up. And typically, a 20 years old male with fatty liver is entirely different from a 60 years old postmenopausal lady. So with menopause, they tend to have metabolic syndrome. Their severity of, fatty liver goes up. Their chances of having fatty liver disease goes up. So a postmenopausal female, as I said, increasing age, gender, especially postmenopausal, will determine. Just look at the AST-ALT ratio. If it is getting reversed, then you start thinking that this disease may be getting little, well, like this patient has AST of 50 and ALT of 48, so slightly, getting reversed. Just look at the platelet count, just simple platelet count. His platelet count is 150. We know the range is 150 to 450,000 of platelets, but it is, as I said, lower limit of the normal. So I think these are some of the things which should, immediately strike you that this patient could be developing a severe form of fatty liver disease. After that, two simple tests which we are saying we should do in our clinic on your mobile. One is known as APRI and other is known as FIF4. So I think any of the residents want to try how do you calculate APRI score? Residents or fellows? No, nobody wants to try. So the APRI is just calculated by two things. You just need to know the AST of the patient and the platelet count of the patient. This patient has an AST of 50. You divide it by your lab's AST value, which is say 40. Then you divide it by the platelets in thousands, which is 150,000, multiplied by 100, and then you get an index called APRI. So what is this APRI can help you in ruling out significant fibrosis in a particular patient. Same is the score in FIF4. In addition to AST and platelet, you also take the help of age of the patient and also take the ALT also into account. So FIF4 has 4 components, APRI has only 2 components. So if your value of FIF4 comes out to be less than 1 or APRI comes out to be less than 0.45, you are almost 100% sure that your significant fibrosis in the liver is ruled out. So if a patient like this comes to your clinic, on your mobile you have calculated APRI and FIF4, you have looked at the age of the patient, gender of the patient, platelet count, AST, ALT, and APRI FIF4 calculated, and this is the score which is coming. I think no need for referral to a gastroenterologist or hepatologist. You can just manage his metabolic dysfunction, ask him to cut alcohol or stop alcohol, and just manage his diabetes, dyslipidemia, hypertension and everything. No need for further, even no need for further testing for non-invasive testing for fibrosis, no need for fibroscan or anything. But if you're not able to rule out, if your values are more than 1, FIF4 and APRI is 0.45, then what we recommend is that you must do a second test to kind of see that whether these tests are right or wrong. Why? Because these tests have an accuracy of close to around 70%. So they are not 100% true. So in this patient, if you look at this, his APRI was 0.8 and the FIF4 is 2.45, which means you are not able to rule out significant fibrosis. Now what should you do in this patient? You should do a fibroscan or a transient elastography. So transient elastography was done in this patient, and this was LSM was 9.1 and the controlled attenuation parameter was 310. Maybe one of the panelists can take, what do you mean by LSM of 9.1 and a cap of 310? Maybe anyone can take.
Hello. Sir, LSM of 9.1 kilopascal seems that patient will be having greater than equal to F2 fibrosis, and that is why patient might require treatment in view of advanced stage of fibrosis.
So as I said, typically to defining significant fibrosis on transient elastography or fibroscan, we usually take a cutoff of 8 or 8.2. So if it is less than that, again you are sure that probably you are 80% sure, again not 100% sure. You are 80% sure that probably your patient doesn't have significant fibrosis. But if it is more than 8, then the chances are that again 70-80% chances that this patient could have significant fibrosis. So ideally, either you do a liver biopsy to confirm that, or you take a clinical decision how do you want to manage that. I think this is what we are recommending. So now comes the last few slides, that now we have established that this patient has metabolic dysfunction associated steatotic liver disease, MASLD, and has an APRI and FIF4 which was slightly high. We have done a transient elastography. LSM is 9.1. So how will we manage this patient? Any one of you can take, please. Dr.
For starting the management, we have to take all the three parameters. One is the alcohol intake should be cut down to non-significant. Once the patient crossed the F2 fibrosis, we have to explain the patient regarding total abstinence for alcohol. Secondly, we have to look for the other components of the metabolic syndrome like diabetic management, as he is on good diabetic control as per FBS is less than 100. But we have to tell him regarding the smooth control of the diabetes, smooth control of hypertension, and good control of his hypertriglyceridemia. Third, the weight loss is very important. The exercise should be started. The diet plan, nutritional evaluation to be done, and one of the dietitians, he should be referred to a dietitian for the proper dietary management, as well as for gradual exercise schedule to be told, like 150 minutes a week of exercise, and gradual even the exercise and diet without any weight loss even will be help him to manage his hepatic fibrosis. And thirdly, the pharmacotherapies will be required in this patient.
I think absolutely right there. These are some of the guidelines which are available. This paper, the INASL guidelines on management of fatty liver disease, is freely available on our journal's website, which is the Journal of Clinical and Experimental Hepatology. So these are the consensus statements, and he's very right. First and foremost is the control of all these metabolic risk factors in this patient, which means control of his body weight. He's obese by the Indian standard, so he should be advised weight reduction. And weight reduction has to be done with lifestyle interventions, which means creating a negative balance with your calorie intake and the calorie which the patient burns. So you need to tell them, cut down your calories maybe by 30%, and moderate kind of exercise, aerobic or a combination of aerobic and resistance exercises, maybe 30 to 45 minutes every day, 5 days a week, if not 7 days a week. And this is what I think, and the target should be around 7 to 10% weight reduction. And yes, the avoidance of alcohol is number one. So the next question is, does he require drugs for management of his fatty liver disease or MASLD? Does he require that?
As such, he crossed F2 fibrosis in fibroscan. So he will require pharmacotherapy, although as per my information, no of the drug is till now FDA approved for the purpose. But vitamin E probably will help, as it helps in not increasing the grade of the fibrosis, and some literature is there regarding the decreased speed of decompensation as well as SCC. Secondly, the new drugs for diabetes, that is SGLT2 inhibitors, and that your GLP agonists will also help this patient, as they will manage the diabetes as well as the metabolic syndrome of the patient. Thirdly, the part that is hypertriglyceridemia should be managed with either statins alone or with statins or fenofibrate combination. Some omega-3 fatty acids are also available for this purpose. So I think with the diet and lifestyle, these pharmacotherapy should also be tried. Pioglitazone as such
I think we'll come down to which drug to use. I think the bigger question in fatty liver disease, as I said, it is so common, is that every second person has fatty liver disease. So you can't be giving drugs to everybody. It's very important to stratify these patients, and if they just have fat in the liver, no inflammation, no fibrosis, you have done a non-invasive assessment, and you feel that, I think they will not require drugs at all. None of these societies would recommend drugs without liver biopsy, except INASL, which we have done, and because we understand that doing a liver biopsy in these patients with a huge burden of these patients is really not possible. So in a select situations, if you think that the patient is not willing for liver biopsy, and on your non-invasive testing, he's turning out to be having significant fibrosis, you can take a decision about giving them drugs on case-to-case basis. We are not recommending to give it in everybody. As I said, ideally, most of the guidelines would suggest that you must document NASH or fibrosis on liver biopsy. Now, the last question is, which drug will you use? As he said, he named some of the drugs, but then these are the 3 drugs which are usually recommended by most of the societies: vitamin, pioglitazone, and INASL also recommends saroglitazar. Now, how to choose between these drugs is again a very difficult scenario. But then anybody, anybody can just tell me, maybe you can take
considering
it up. How
our
will you
patient,
choose between these 3 drugs?
Sir, considering our patient is diabetic, we will not be going with vitamin E because it is not recommended because of risk of hemorrhagic strokes in those patients. Our patient is elderly, so there is risk of prostatic malignancies also with vitamin E. Then with regard to, since our patient was having diabetic dyslipidemia as well in the form of increased triglyceride, diabetes, so we can consider saroglitazar, which has effect on diabetic parameters as well. We can also go with pioglitazone in dose of 30 to 45 milligram. But
so absolutely, I think this is, there are certain guidelines. Again, as I said, the time will not permit me, but then you can look at this paper. You can choose between these 3 drugs depending on the patient profile. If somebody has a diabetic dyslipidemia, your case for saroglitazar becomes very easy. But if somebody doesn't have that, then I think you can choose between, typically pioglitazone we don't use much in clinical practice because of the side effects, pedal edema, cardiac issues, weight gain. So our choice usually is between vitamin E and saroglitazar. And as he rightly said, if you have an elderly patient, risk of prostate malignancy or other things, we tend to avoid vitamin. Lastly, how do you stop? I think we can skip this. And you discussed about the management of, the metabolic risk factors. I think this is the last important question, which I would say it's important. Somebody like this comes in. Does he require, other than the management of fatty liver, I think we must have a holistic approach in managing these patients. Does this patient require evaluation for cardiovascular or other diseases, or we are fine just looking at the liver and we leave rest everything else?
Yes, all the cases of the metabolic disorder, we should rule out the cardiac causes. Cardiac disease like ischemic heart disease are associated hypertension and diabetes. So in these cases, we should go thoroughly for lipid profile and electrocardiogram. And in some cases, if there is symptom of the dyspnea, or then we should go to the echocardiography for
So
cardiac evaluation.
So the message here is that the diabetes, as you do in other patient, as long as they are in a pre-cirrhotic stages, and we are discussing a pre-cirrhotic patient today, statins, even if they are indicated, can safely use these patients. But yes, how far to go? And as we said, most common cause of death in a patient with fatty liver disease, an early part of the disease when they have only grade 1 or grade 2 or fibrosis, stage 1 or stage 2, and so that in that time the most common cause of death is cardiovascular disease or malignancy or something else. So what do you do? I think there are no clear-cut guidelines whether everybody should be subjected to a detailed cardiovascular workup, but yes, as the liver disease advances, I think now people are recommending that yes, you should look for maybe their urine routine examination to see whether they could have proteinuria, which could indicate that they could be developing CKD. If they're developing again NASH and fibrosis, you could also be probably screening them for cardiovascular disease, especially if they have diabetes and hyperlipidemia. But things are not very, very clear. I think these are, I would say, evolving areas. So let me conclude by saying what I discussed in last few minutes is that please define your patient correctly. Whether you want to call it as MASLD, whether you want to call it as MET-ALD, start following the newer definition. Start just look at the metabolic dysfunction and fatty liver. You are MASLD. It could be combination of various. All patients with fatty liver are not same. Do the risk stratification, and you can use the clinical parameters like age of the patient, gender, platelet count, AST, ALT, and then use two simple scores, EPRI and FIB-4, and then take a call whether you want to treat these patients only with lifestyle interventions or you want to add some drugs only if they have significant fibrosis. And the three drugs we discuss is vitamin E, pio, and saroglitazar. Also, I would recommend that you must have a holistic approach. Just look at other organs also, not only at the liver, look at, the other organs, especially cardiovascular disease and kidneys and all that stuff. So thank you very much for your kind attention.
Thank you, Dr. Ajay, for a lovely presentation and discussion. I thank you for conceptualizing this clinics, as well as Dr. Patrick, who consented to do this, and Dr. Dikshit to have it organized in Varanasi. Any questions?
Sir,
Yes.
I just want to ask the role of UDCA in MSLD. This is a very general question for DM, MD residents and for physicians. So UDCA.
There are n number of drugs which have been tried in patients with steatotic liver disease, and many of these drugs were found to give you what we call the biochemical response, which means that they could reduce your serum transaminases. But when these placebo-controlled studies were done in these patients, especially histological based, they were not found to be useful. So to cut it short, UDCA is one such drug which was found to be useful in improving your liver biochemistry, but when was done as a placebo-controlled study to look at the histological efficacy, it was not found to be useful. So you can use it maybe just like maybe not more than a placebo, I would say, but if you ask me whether it is recommended for these patients, the answer is no.
Thank you, sir. Thank you, and I guess we would end the session as we are running late of time.
Thank you.
Thank you, sir.
Thank you.
Thank you, respected chairpersons and panelists. You can please take your seats. So for the next session that we have is compensated cirrhosis, diagnosis and management. I would like to invite on the dais the chairpersons for the session, Dr. Yogesh K. Chawla, sir, ex-director PGI Chandigarh, ex-professor and head Department of Hepatology PGI Chandigarh, ex-president INASL and currently professor of hepatology in Kalinga Institute of Medical Sciences, Bhubaneswar. And Dr. Devesh Prakash Yadav, Professor and Head of Department of Gastroenterology, IMS BHU. Please take your seats and I would request the chairpersons to call upon the dais the panelists for the session.
I will call on the dais Dr. Anurag Kumar Tiwari. He is Assistant Professor in Department of Gastroenterology, IMS BHU. Professor K.K. Tripathi, ex-professor and head Department of General Medicine and Nephrology, IMS BHU. He is my teacher also. Dr. K.K. Tripathi, please.
I would request the chairpersons to invite on dais the speaker for the session.
Patrick, let's have you again and discuss with us compensated cirrhosis diagnosis and management.
And Ajay, thank you for a good discussion, and what I'll say will follow some of what you have also said. Okay. So if you have some spare time, try and look at this site. It'll show you what the universe is around us. We are a very small part of the universe. So I look at this often. And can you see this? This is called the Small Magellan Cloud. And it looks like the liver. It's very bright. So for those of you in DM, remember, future of hepatology is very bright. Okay? So consider hepatology as one of your choices. Okay. So patients with chronic liver disease can progress to cirrhosis, and the onset of several features denotes the onset of decompensated cirrhosis. So in all these situations, there are precipitating events, viruses, drugs, alcohol especially, which will give you a combination of hepatic and extrahepatic organ failure, and this is acute and chronic liver failure. So, you know there are precipitating events in here, and as Ajay told you, make sure about immunizations and all, because your goal, especially as physicians, is to institute prevention in all patients with chronic liver disease. So let's try again. Physical signs of compensated cirrhosis. Which are the physical signs? Spider nevi? Anyone? Some? Erythema? Parotid enlargement? Deputin contracture? Panel, do you want to take that up? What do you think? Which are the features of compensated cirrhosis?
So spider nevi, caput medici, and palmar erythema, even parotid enlargement and deputin contracture, all may be present in a patient with compensated cirrhosis.
You're sure? You're sure? So remember one thing, that is why it is so important, as Dr. Duseja told you. This is where the FIB4 and all come in, because ascites is usually the first manifestation of hepatic decompensation. So compensated cirrhosis is the asymptomatic phase. You have to pick them up at that phase. And so typically you're going to pick them up, and if you have a patient who's obese or who's drinking and who has diabetes and all that time. And peripheral signs of cirrhosis are typically absent in these patients. It's a much more advanced phase. You don't have to shouldn't pick them up so late. You should pick them up earlier in that. And death in the compensated phase is from cardiac disease or from cancer. Okay, so this is generally. And ascites, 60 to 70% of first sign of decompensation is ascites in these patients. So in this talk, especially for physicians, I'm going to go over how do you diagnose cirrhosis, how do you prevent decompensation, and when you see the patient, you have to know what the prognosis is. Always good to discuss with the patient prognosis. We'll go over immunizations, which drugs are safe in them, what drugs should you use, surveillance of hepatocellular carcinoma, and then finally, we'll have some take-home messages. Okay. First, does my patient have cirrhosis? So we have fibrosis estimation, you have serum biomarkers, and you have imaging. Okay, so you have two things. So you can typically do these independently or sequentially, depends on what you have available. Now, for non-invasive diagnosis of cirrhosis, Ajay, as far as I know, there are no commercial markers here, right? Good. So the question is, should we get commercial markers in India? Question one. Is transient elastography, does it examine a big portion of the liver or a small portion? And does MRE examine about 100 milliliters of liver? Do you want to take that on the panel? First one. Are they better than FIB4? So do we need some?
Yeah, I think US elastography is better than FIB4, and MR elastography is even better than...
No. Biomarkers. There are commercial biomarkers available. ELF, BARD. Should you get them in India? Are they better? That's my question.
Sir, I don't know.
Okay, good. Okay. Ultrasound transient elastography, does it examine 100 milliliters of liver, more or less?
It examines a very small portion of liver.
Good. MRE, 100 milliliters of liver, more or less?
It can examine entire liver.
Elastography typically gets a section, but more than ultrasound. So we'll go over that. So this is what we so as Ajay told you, manage with FIB4 and APRI. These commercial markers are expensive. I know there are companies which are pushing for these markers, but you don't need them. So FIB4 and APRI are enough for most patients. Ultrasound transient elastography. So you can see in a very obese patient, it's not going to be so good. You need about 2.5 centimeters from the probe. It gives you a very small volume of the liver. So you can see about 4 centimeters length, 1 centimeter diameter. And based on that, you come up with certain scores. So probably 5 or 6 is normal, 7 is a little on the higher side, but less than 7 is normal, fibrosis 7 to 12, cirrhosis greater than 12, and clinically significant portal hypertension greater than 15. So you're absolutely right. Typically, only a small volume of the liver is examined. Now we come to MR elastography. This is one of my colleagues, Dick Eman. He invented this. So the way it works, elastography measures stiffness, okay? So sound waves go very rapidly through stiff objects, so it measures how fast the sound wave goes. And soft, like a pillow, sound waves don't go. So a liver is typically soft. So you have an active driver and it sends sound waves. So this is what the type of picture that you get with the sound waves going through the liver. And based on that, you come up with an elastogram. Okay, so violet, indigo, blue, green, it means the liver is a little more stiff. Yellow, orange, red is getting into the cirrhosis range. So elastography takes slices. So typically 250 milliliters of the liver is examined. And one advantage is you have orientation. With the image that you get on elastography, you don't have orientation. You don't know which part of the liver. Here you can get regional differences and you can see stiffness in that. Problem is it's a much more expensive test and more difficult to get, but it's a better test than ultrasound. Elastography. So here is how you interpret MRE. Less than 2.9, normal, no liver biopsy. 3 to 4.9, fibrosis. You don't need biopsy, but some studies require biopsy, but typically you don't require. The problem is if it's more than 5. So platelets are okay. Occasionally you will come up with this number. Your suspicion for cirrhosis was low and yet the stiffness is high. When there's discordance like this, you should do a biopsy. But if you have a high suspicion of cirrhosis and it's more than 5, that's enough. Again, you don't require a biopsy. Okay, so you do serological markers and then you get some assessment of elastography. The problem is all elastography, if you don't do it right, you have problems. So if you don't fast, cholestasis, obese, inexperienced, cardiac disease, infiltrative disease of the liver, all of those will give an increased stiffness. So you have to know the situation in which you're checking. So again, for physicians, this is how you're going to diagnose cirrhosis. First, patient has chronic liver disease, hemorrhage, ascites, encephalopathy. That's usually enough for you. If it's yes, you liver biopsy, you don't require for diagnosis. If you don't have any complications, when you examine them, if they've got some stigmata of chronic liver disease, splenomegaly, thrombocytopenia, if you have that, again, no liver biopsy required. Physical findings and laboratory findings, not clearly cirrhosis, imaging showing you a nodular liver, collaterals, or ascites or splenomegaly. Again, if you have that, that is cirrhosis. If you don't have that, and you have a strong suspicion of cirrhosis, only then you have to do a liver biopsy. So this is your evaluation. So now you've done markers, you've done imaging, small number of patients, you require a liver biopsy to make a diagnosis of cirrhosis. Okay, so now you've diagnosed cirrhosis. Now you have to prevent hepatic decompensation. So let's see, weight loss. If you lose weight, do you decrease risk of hepatic decompensation? Show of hands. Low portal pressure, good. Weight loss is good in these patients. How much weight should you lose? 3, 5, 7, 10 to reduce steatosis? So I'm giving you these numbers. Do we have validation in India? Yeah, same guideline. So this is probably a simple study for someone to do here. You've got huge number of patients, especially if 40 to 50% have it. So I think we're good to validate it. It'll be a very good paper here. So how do you prevent decompensation? Most important, treat the cause. Also, doesn't matter what the cause is, no alcohol, try and make them lose weight, okay? Prophylaxis against varicose bleeding, we'll talk about that. Immunization, as Dr. Daseja told you. Be careful about using some drugs. We'll talk about that in more detail. Okay. This is what we know. Studies which showed increased fibrosis had higher risk of decompensation. Obese patients who had cirrhosis, higher risk of decompensation. And diet and exercise reduced weight and portal pressure. So weight loss is good for these patients. But weight loss is difficult. Some of you have seen this slide before. What are you most scared of? Sharks or burgers? Sharks attack and kill 10 humans worldwide. Okay, sharks don't kill. Don't get scared of sharks. Be very scared of this. Burgers attack 116 million people on any given day in the US alone. From the time I started my talk till I finish in 30 minutes, how many burgers will be sold worldwide? Worldwide, 8 million burgers will be sold worldwide in this 30 minutes of my talk, okay? Question for you. I'm talking about burgers. Do pizzas, burgers, pasta Alfredo and chicken sandwiches? I picked this up because this is a British Medical Journal studies. Do they have higher calories than a good masala dosa? If one of you wants recommendation for good masala dosa, ask me. I'm an expert. I'm from Bangalore, which is the world's best masala dosa. There are several places. What do you think? Who thinks burgers and all have higher calories than a good masala dosa? Any? 1, 2, 3, 4, 5. So the rest of you think masala dosa has more calories? Anyone? Who thinks masala dosa has more calories? 1, 2. Okay, so this is a study in the BMJ. So this is, the India site was Bangalore. So they went to restaurants and got food. And they use a bomb calorimeter. That's the most accurate way of measuring calories. And this is what we find. So Western fast foods in Bangalore, I'm only talking about Bangalore, but this is part of the BMJ paper. This is the calories, single serving chicken pizza, Alfredo, chicken sandwich, and meat burger, 567 calories. The 1809, mutton biryani 1464, jeera rice with chicken curry 1890. Okay, so again, we have to be a little careful about our foods. First line therapy, dietary choice. I think the traditional Indian diet is a very good diet. Vegetarian, lentil-based diet is very good. As Ajay told you, 30% energy reduction. Minimize refined carbohydrates, sweets, sugars, and to me the worst is ultra-processed foods, because anytime I come, I keep looking in the stores and every time I see more ultra-processed foods. So I think that is the killer for obesity. Exercise, some resistance exercise. We know in COVID, those who had muscle did better than those without muscle. If you don't have muscle, you cannot come off the ventilator. So generally, all of you put on some muscle. South Asians, our big problem is A, obesity, B, sarcopenia. So we have sarcopenic obesity, which means even at a lower BMI, we have a problem and we have less muscle. So try and build some muscle. We don't know exactly which exercise is good, but again, Ajay told you about 150 minutes per week. There are weight loss options. I gave you lifestyle changes. Most people, of course, don't like lifestyle changes. And generally, again, I think this is something that should be replicated in India. I think that because the study is from the West, How much weight should you lose? I go over with patients, and if they have cirrhosis, I'm really shooting for 10%. But remember, there's a problem. If they've got decompensated cirrhosis, they're losing muscle, they're losing weight. So this is only for compensated cirrhosis. Person is overweight, I shoot for 10% weight loss. Again, whether this is right in India, I don't know. So we're trying to reverse the cause. Next is we want some prophylaxis against variceal bleeding. And we'll go over a little more details. If they have no varices, endoscopy in 3 years. If they are compensated, then we go 3 years. Decompensated, we'll go in a year. Small varices depends on the signs. If they don't have red signs, then repeat endoscopy 1 to 2 years. If they have red signs, then beta blockers. Typically, non-selective beta blocker, carvedilol. So for physicians, we want a non-selective beta blocker. Goal is 25% reduction in. Right? If you're median or large varices, then either beta blocker or endoscopic variceal ligation. So you have to discuss this with the patient. So in terms of bleeding, both are equal, but beta blockers may reduce all-cause mortality. And generally, if you're working up these patients, if they have liver stiffness less than 15 and platelet count more than 150, they probably don't need an endoscopy. Their risk of clinically significant portal hypertension is very low. I'll talk a little more about beta blockers in my following talk. I also like to discuss with patients prognosis. So once you say cirrhosis, they get really worried. So what do you tell them they're going to die of? Who's going to tell them compensated cirrhosis? Risk of dying variceal bleeding, HCC, hepatic encephalopathy, cardiovascular. Good. That's what you should focus on. The risk of death is cardiovascular. So in compensated cirrhosis, on cirrhosis related to MASL, it's probably even longer than that, which is good. So they have a good survival, and deaths are non-liver related. So use this time that you have. Once you make a diagnosis of cirrhosis, get them to lose weight, do some cardiovascular protection in here. Again, for MD students, do you calculate what's called the ASCVD? You do that? Good. Someone is nodding. Good. So when will you start statins? ASCVD, what risk? So you're trying to, it's a simple calculate in these patients. Yeah, you nodded, yeah, do you know? So generally, it tells you a risk of cardiovascular disease significant in 10 years. So if your score is more than 15, you must be on a statin, so moderate intensity statin. If you're diabetic, which is going to be many of these patients, 7.5% cardiovascular risk in 10 years, you will start them on statins. So your threshold for starting statins depends on your cardiovascular risk. So calculate it in these patients because this is what they're going to die of. Who is going to decompensate? Who should you watch a little more carefully? We don't do pressures. If you find their MELD score is going up or their serum albumin is going down, watch them a little more carefully because you know these patients are going to have hepatic decompensation. So usually I see my patients with compensated cirrhosis once a year. Once I think they're decompensating, then I see them after 6 months. Immunizations. Which is contraindicated? Panel, do you want to take? Which of these is contraindicated in cirrhosis?
None of these are contraindicated.
Very good. None are contraindicated. So please immunize your patients. COVID, pneumococcal influenza, tetanus. These are recommendations from the West. What are the recommendations here, Ajay, besides hepatitis B? Is COVID, are you recommending it for all your patients with cirrhosis? No? Pneumococcal? Pneumococcal, okay. So maybe if you can tell them which ones you're recommending for immunization.
Yeah, I think predominantly those who are on a transplant waiting list, we would immunize them for pneumococcal and hepatitis B. Rest, I think we really don't.
You don't do that, okay.
Sir,
Which one? You immunize here? Yeah, I mean, so it's a question of the practice.
sir, we can start immunization against hepatitis E virus in future. Hepatitis E virus.
Hepatitis?
E virus, because that can cause ACLF in.
Is the vaccine available?
No, not
Not
available,
yet,
but
it's
in
available
coming
now
future
in
it may be
China.
available, sir.
It's available in China now.
I think it's good because, you know, I always thought hepatitis E was related to poor hygiene. I had visited Switzerland about 3 weeks ago, and they presented patients to me with hepatitis E. Switzerland, the cleanest country in the world, has more hepatitis E percentage-wise than we have. 15% of all meat products in Switzerland in the grocery store carry hepatitis E. So it's carried through meat products in there. And they have chronic hepatitis E in their transplant population. They have in the transplant population and immunosuppressed, they've transmitted hepatitis E through blood transfusions too. So they are checking all blood for hepatitis E also. Yeah, so I don't know about vaccine. There's question about how effective the China vaccine is. I don't know how effective it is, but if there's a good vaccine, yes, to be tried. How's the hepatitis B program going nationally? I remember reading, so it was supposed to be at birth and then with oral polio vaccine attended. So birth, 6 weeks, 14 weeks, 6 months, that was how it was going to be done. In 10 states, only 5 were doing well. How is it doing now? Is it better?
It's a universal. It's in the national immunization program.
No, correct. But how is everyone getting it? So that was the study which showed 5 states were doing well and 5 were not doing well. My state was doing well, Karnataka. You're doing better? Okay.
Actually, most of the institutional deliveries are getting, newborns are being vaccinated with hepatitis B virus.
West Bengal is doing extremely well, that I know. Because at least I'm only reading papers, I don't have pressure. Yogesh?
Patrick, as of now, 70% of the newborns are vaccinated.
Correct, so that.
In spite of the universal immunization program.
That is what I was saying. Because the goal is 90%.
Yeah.
And so it's still under 90.
Yes.
Yes. I mean, that's, because hopefully it should be 90 or 100%, which will be good. So again, as Dr. Daseja told you, antibody response. So if the liver disease is bad, your antibody response is not good. So vaccinate these early. Live attenuated message, vaccinate early in cirrhosis. Then you have to some care with taking drugs. What about statins in cirrhosis? Safe or not safe? Safe? Decompensated? Correct. Good. So this is what we know. So there's safe drugs. I love statins. Statins overall decrease cardiovascular risk. So hopefully, I've been on statins now for 33 years. So maybe a decreased risk, and I never check my liver test. So initiate statins, but there's a bit of a problem, okay, as someone pointed out, compensated cirrhosis. So the initial study of pravastatin, with there's always this hydrophilic and hydrophobic statins, but pravastatin in patients with chronic liver disease showed excellent safety, which the expert liver panel with Naga Chalasani was also on that, said presence of chronic liver disease and child-stage cirrhosis is not a contraindication for statin use. So no big studies were done on decompensated cirrhosis. Most recently, there is this study. Simvastatin was safe at 20. At 40 was not a liver problem, was rhabdomyolysis is higher. So In decompensated cirrhosis, you have to be careful. So generally what do? If a patient is on statin and gets decompensated disease, we will continue. If the patient has decompensated disease, we do not start a statin. So pharmacotherapy, pain relief. Anyone, what drug will you use for pain relief in cirrhosis? Okay, pain not going away with paracetamol. What will you use?
Opioids.
Opioids.
Opioids, sir. Tramadol, opioids.
You're sure about tramadol? Tramadol is a good drug for pain, but the question is in cirrhosis. There are studies on cirrhosis. We'll talk about that. So, okay, anti-inflammatory. Patient has arthritis. You know, you're getting an older population. They're going to have arthritis. Paracetamol not good enough. What are you going to use? These are questions, especially as physicians, you will have to answer because you're looking after these patients. Which drug are you comfortable using for anti-inflammatory?
I think indomethacin.
So good. So you can start off with non-steroidals with compensated disease, okay? With decompensated, we don't want to use. So if you have decompensated disease and they have inflammatory arthritis, so you see the joint swollen, inflammatory, you know you cannot use non-steroidals. So what will you use? I heard someone.
Sulfasalazine.
I don't know how good that is, you know. Sulfasalazine is much better for maintenance and low level. You know, you get a swollen joint, sulfasalazine. This is where you use steroids. So in patients with cirrhosis, with inflammatory arthritis, and they're decompensated, move to steroids early in these patients. Antibiotics, which are your preferred antibiotics, which are generally safe, which are generally you don't need to make dose reductions in patients with liver disease. Which ones do you want to use? You said something? Loudly, don't worry. Very good. So cephalosporin is a good drug. Anything more? You use them all the time. Quinolones are good drugs. Remember, we'll talk about. So I'll go over the list in a bit. If they've got diabetes and they've got cirrhosis, do you want insulin or oral hypoglycemics? These are questions which you're going to get all the time. What do you prefer?
Insulin.
Everyone. All cirrhotics insulin? Okay, we'll talk. Okay, so this is what we generally do. Paracetamol is okay, less than 2 grams daily. We avoid non-steroidals with decompensated cirrhosis. Okay, so that's when we will go to steroids. Antibiotics, fluoroquinolones, penicillin is a very safe antibiotic in these patients. Cephalosporins, but remember each one of them can have an idiosyncratic reaction, but generally they're safe drugs, so you can use them. You don't need to reduce the dose much. Statins, acceptable, except in decompensated disease. Oral hypoglycemics, you're okay. So most of your patients are going to be compensated disease. You're fine continuing whatever oral hypoglycemics. It's once you have decompensated on oral hypoglycemics, they tend to get hypoglycemia, poorer control of diabetes. In them, you require short-acting insulins in these patients. So that's your take-home message for physicians. HCC surveillance. Surveillance needs to be carried out for these patients. So HCC surveillance, all patients with cirrhosis, irrespective of child class? Irrespective of child class? Sure? Okay. HBV and family history of HCC. HBV and all Asian males over 40. HBV and chronic hepatitis. Good. So the only wrong one here is A. Okay? We'll talk. So this is multi-society guidelines. So we've taken from multi-societies. Cirrhosis, child A and B, sure. Patient has decompensated disease, not a candidate for transplant. He's got ascites, he's got encephalopathy. If you've got a small HCC, what you're going to do about it? So patients with cirrhosis awaiting liver transplant, then it's worthwhile doing surveillance. Otherwise, the benefit is very limited in these patients. Non-cirrhotic hepatitis B, you're all correct. If you've got active hepatitis, family history, Asian males over 40 and Asian females over 50, you will have to do surveillance for hepatocellular cancer. So these are the multi-society guidelines, including from APASL. So take-home messages on compensated cirrhosis. Patients with compensated cirrhosis are asymptomatic and without signs of cirrhosis, so please use APRI and FIG4. So diagnosis of cirrhosis is usually made by exam, serum biomarkers, elastography, and imaging. Your goal, cause, no alcohol, lose weight. And don't forget, patients are at risk for cardiovascular disease, especially with compensated disease. Calculate their risk, start statins if needed, and they're also at risk for malignancy. Thank you.
Thank you, sir. Thank you for the very informative session. Any questions from the audience? From the panelists?
Two questions. You said about the beta blocker used for the prevention of the variceal bleed in cirrhotic. Can be old propranolol, which we have been using so far. Is there any difference?
So the question is which beta blocker? I'll also be going over this in my session on decompensated disease. We need a non-selective beta blocker. Cardioselective beta blockers only decrease cardiac output. We need something which acts on the splanchnic circulation, which is beta-2 blockade. So we need a non-selective beta blocker. Carvedilol, in addition, has alpha blockade, so it decreases resistance within the liver. So carvedilol is the best. But if a patient has been doing well on propranolol or nadolol, long-standing, and there's no need for carvedilol, we will just continue them on the same medication. The problem with propranolol is if it's the short-acting one, then you have to give it 4 times a day. Patients forget. You have to use the long-acting one. So non-selective beta blockers try once a day in the evening. So even carvedilol, start with a twice daily dose. Once you've achieved target, then go to a once daily evening dose. And I'll go over that in my talk on decompensated. Any other questions?
Second question. You said about the sarcopenia. Most of patients in this part of country, about cirrhosis, decompensated otherwise also, are very cachectic. They are very sarcopenic. Hardly have any flesh. Even you cannot make out any fat when you look at the skeleton. So what is there any drug or can we do anything more? Because they cannot do exercise.
So the question is sarcopenia. And you know, this is something which has not been well studied. We know sarcopenia is associated with poor outcome in these patients. So there are what are called myostatins. So there are drugs which they're trying to increase muscle mass in these patients. Of course, anabolic steroids do that, but we don't routinely try it. If the testosterone levels are low, you can replace testosterone. It's in cirrhotics, it does not further decrease muscle mass. It doesn't increase muscle mass or not. But so generally we say nutrition and exercise.
Unfortunately, they have a lot of insulin resistance also. These are the patients who have insulin resistance, sarcopenia, obesity, and they are very poor in eating, doing exercise. So that's the problem.
I mean, so when we're talking about areas for further study, I think this is sarcopenic obesity is a big problem, and I think that contributes. The Koreans have done some work on that. So they were the first ones to show that their risk of fatty liver disease is higher. I think we should do a lot of work on sarcopenia. Yeah, that's another big area we can do research.
So do we need to have varices or endoscopy before to start beta blocker therapy, or we can start if it is not there?
So there's the rule of 5s, normal stiffness less than 5, over 10 cirrhosis, 10 to 15 unlikely to have clinically significant, over 15 with thrombocytopenia, likely to be clinically significant, over 25 clearly. So based on some of these, you can start a patient on carvedilol. You can. But in between, there's a gray area. About 40% of patients may have stiffness, but platelets are okay. They will require the endoscopy. One of the things, again, it's probably worthwhile doing studies here. All this was based on retrospective data in patients in whom they started beta blockers and followed them. When they looked back, these were the cutoffs. It has not been looked at prospectively. You know, if these are the cutoffs, if you start them, what is the advantage? That has not been looked at. But yeah, I think it's reasonable to start. If they tolerate it, okay.
Thank you, sir.
Ajay?
Just quickly in 2-3 issues. One is when you're talking about the NITs for assessment of fibrosis and mainly on the elastography. In India, and I'm sure, I don't know whether it's licensed in US, we have these ultrasound-based shear wave elastography, mainly which they use the technology called the RFI technology. They are also freely available, rather more freely available than the transient elastography. So always a big question in physicians' mind would be whether the shear wave elastography done on those machines will be as good as done on a FibroScan machine or a EcoSense machine or a transient elastography. I think that would be one. The second thing, again, we have published on this is you mentioned about the inaccuracy of FibroScan in various clinical situations. One of the very important situations what we face is the patients with ESRD, the end-stage renal disease, those who are on dialysis. They are fluid overloaded and their values actually turn out to be high, and the decision becomes very difficult whether to do only kidney transplant versus liver kidney combined. So there we had published that we must do the transient elastography post-dialysis in these patients. And there we had shown that the value really comes down significantly. And the last question is about doing endoscopy here in India, whether that is easier to look for portal hypertension or following this algorithm of LSM of more than 25 with platelet 150, because as I said, the FibroScan may not be that easily available or maybe costly, whereas endoscopy is easily available and cheaper in India. So I think that.
Yeah. So actually, Ajay, I'll answer the last question first. I'm much more comfortable with endoscopy than these because I told you they've been based on retrospect. So until you're comfortable with that, generally it is recommended that a person does 100 of these elastograms before they achieve competence, okay? So yes, chronic kidney disease is associated with increased liver stiffness, and our personal thing in these patients is we will do a biopsy in these patients before considering liver transplant with kidney or kidney alone there. So typically we go a liver transplant. And your first question was related to, correct. So the advantage of shear wave, so the FibroScan transient elastography is a standalone machine which you can have in your office, whereas that is ultrasound based and with radiology. And the studies on that are very limited. Oh, no, I agree, but I think we had a lot of trouble initially when we had shear wave elastography with the radiology, and they were having a lot of difficulty with standardizing. So yes, that's a problem.
Thank you, sir. Thank you for a very informative session.
Patrick, just 2 points for the House. From the sonographer of heterogeneous ecotexture of the liver. I think the importance of that, this is very subjective and we should not take it on the face value that this is cirrhosis. And secondly, not all nodular livers are cirrhosis. You have conditions like nodular regenerative hyperplasia, non-cirrhotic portal fibrosis. So that has to be kept in mind, and FibroScan or FIB4 will tell you the difference between the two.
No. So there are problems with elastography, and we know. So, for instance, the European study with the screening populations, they did the fibroscan, showed it was elevated. And so typically they tell the patient, it's elevated. Part of the study was to do a liver biopsy, which is about 4 to 6 weeks later. So patients got worried, started losing weight. When they came 4 to 6 weeks later and they did the fibroscan, the elastogram was close to normal. So even a short period of weight loss decreases elasticity. And the second is stopping alcohol use. 3 weeks after you decrease alcohol, the stiffness seems to decrease in that. And Yogesh, you're right. Nodular liver is not cardiac disease, which is something which I see a lot of. Cardiac disease with time tends to give you a nodular liver too in there. So yes, all nodular livers are not cirrhotics.
Fine. Thank you, Patrick. I think it's time that we close this session.
Yes, sir.
Over to the
So,
comp.
yeah, so we'll be ending this session. I'll request all the dignitaries to take their seat in the audience, and I will request Professor Kamath to be on the dais as he is the next speaker. Sadly, we have to skip the coffee break as we are running late off the time. Those who would like to have refreshment can take it from the counter and get back to their seats. So for the fourth case, I would like to invite on dais the chairpersons for the session, Dr. S.K. Yadav, sir, Senior Consultant Gastroenterologist, Varanasi, and Dr. Vinod Kumar, sir, Assistant Professor, Department of Gastroenterology, IMS BHU. I would request the chairpersons to call upon the stage the panelists for the session.
So good evening, everybody. So I'll be calling Dr. Vineet Mishra, consultant, Varanasi. So I'll ask Dr. Ravikant Thakur to join us at dais for panel discussion.
So Ajay, your panel stayed. Okay. So difficult is to treat symptoms in patients with cirrhosis, okay? So when we do a liver transplant, we do liver transplant either to increase quantity of life or to improve quality of life. So that means if we cannot improve quality of life, we do a transplant. So it's very difficult to improve quality of life. So patients have multiple symptoms which you need to work on. So generally, remember, you cannot improve quality of life significantly in most patients. But so generally your goal is try and help them a little. So in this talk, I'll go over how much of a problem it is, what is the impact, what are the determinants of health-related quality of life, some management approaches, and take-home messages. Okay. Generally, quality of life has not been studied in cirrhosis, and we don't have a very good way of actually measuring quality of life in these patients. But whatever studies have been done, how big a problem is? So if you look at patients with cirrhosis, the number of symptoms they have is equal to advanced malignancy. You've looked after patients with malignancy, you know how many symptoms they have. Patients with cirrhosis have equal number of symptoms. If your quality of life score is 100, mean quality of life score of patients with cirrhosis is 59. Also, patients have psychological stress, family worries, social stigma, financial distress. Then you put them on a transplant list, even more stresses. So your patient with cirrhosis is symptomatic and quite stressed. Not only the patient, it's the caregiver. So this is a study from Jazz Bajaj to show that looking after a patient with cirrhosis is like looking after a patient with Alzheimer's or advanced cancer because they have multiple problems. And the caregivers also have problems themselves. They have depression, anxiety, and all. So try and help your patients with cirrhosis. So to summarize, the quality of life of patients with cirrhosis is poor, not only in the patients, but also in the caregivers. Okay, so it's a huge problem. So what is the impact? If they feel poorly, more likely to be hospitalized. Even though the liver disease is the same, if you have more symptoms, you're more likely to seek hospitalization. And if you try and get them to feel a little better, you reduce their risk of hospitalization. Also, patients who feel poorly have a higher risk of mortality. So they have worse quality of life. So relative risk of mortality is higher in these patients. Okay, so to summarize, message is poor quality of life is very common in patients with cirrhosis, and poor quality of life is associated with increased risk of hospitalization and mortality. So the question is, why is their quality of life so poor in patients with cirrhosis? Hepatic encephalopathy, ascites, fear of rebleeding, all this makes it risky. Pruritus, depression, pain, cramps, sexual dysfunction, sleep, other symptoms, all of which poor quality of life. So how are you going to manage these patients? So symptom relief. So generally when we diagnose a patient with liver disease, we're trying to cure the patient, and that's possible initially. So you try and treat the hepatitis C, hepatitis B, but after some time when you fail, and especially with cirrhosis, it's going to be mainly palliation of symptoms, okay? And I think that's very difficult because this is not typically taught. So let's go over the thing, fatigue. Patients are very tired. You've looked after patients with cirrhosis, right? Do they say they're tired?
Yes, they say we are tired, we are feeling generalized weakness and malaise.
So how do you manage them?
For fatigue, we, like I personally advise, good nutritional support.
So nutrition is good, okay?
Daily adequate exercises, whatever allows.
Agree. Some exercise, nutrition.
If we'll assess for vitamin deficiencies and nutritional deficiencies, we will supplement
nutrition, that. Okay.
And apart
so
from
which nutritional deficiency are you looking at?
Zinc, carnitine, vitamin D, B12, these patients are generally deficient.
So vitamin D, important, I agree. Okay, so fatigue, okay. Sleep, they tell you they're not sleeping. What do you do for that?
These patients may have altered sleep pattern, mostly they are early encephalopathy patients. So in these patients, we try to evaluate for hepatic encephalopathy, and will add rifaximin and lactulose, like lactulose plus minus rifaximin as an add-on therapy.
But can you get sleep problems without encephalopathy?
Yes, we can.
Is your only diagnosis, if they're not sleeping, is hepatic encephalopathy your only diagnosis?
No, if patient has altered sleep pattern, if patient is awake on morning, and even then if patient is not sleepy, we will root out any associated anxiety and associated psychiatric illnesses also.
Okay, but no medication for sleep.
Also, patients who are alcoholic, once we tell them to stop taking alcohol, they frequently complain about sleep. And what I have seen that those patients who are in decompensated state, with even with a small sedative, they land up into hepatic encephalopathy. So
No, I agree. So when they, especially alcohol, and they have sleep, what drug do you use? You don't use any drug? So the question is, are any medications safe? That is my question. Melatonin, well, that's reasonable. Muscle cramps. Out of all the symptoms patients complain of with cirrhosis, and they say no one helps them, muscle cramps is number one. The most common symptom is fatigue. The ones they say no help at all, makes them miserable, is It's very frequent. How do you treat that?
So in muscle cramp, first we'll rule out any electrolyte imbalance patient, mostly on diuretics. And if electrolytes are normal, we generally start with, like we'll test for vitamin B12 and D deficiency.
So the electrolyte problem, if you correct the electrolytes, does the cramp go away? I know it is often, people say it's an electrolyte problem, diuretics. If you correct the electrolytes, does the cramp go away?
In a subset of patient, it goes away.
Big subset or small subset?
Small subset.
Yeah, it hardly goes away. So you can check, you can correct it. You feel happy that the electrolytes look normal. Patient's happy that the potassium is now looking better, but it doesn't help the cramps. So what medications what will you recommend for that?
If vitamin B12 is deficient, we'll add that. And in few patients, adding carnitine also helps in small subsets of patient will improve this cramps also.
So albumin and baclofen.
Sorry,
Albumin and baclofen.
Reasonable, okay. Pruritus. How do you treat pruritus? That's another always, my recommendation to the panel has been, if a difficult question comes, give the mic to the next person. Okay, always do that. That's the best way to. So that is a good move, good move. Now your chance to give it back when you ask, okay, pruritus, how do you manage?
Usually we do not see a lot of patients with cirrhosis having pruritus. If they have superimposed...
Okay, let's say if they've got pancreatic cancer, untreated. Cholangiocarcinoma is common, right? Gallbladder cancer going into again common. They get pruritus. How do you treat?
So we can give Atarax, we can give levocetirizine.
Atarax is phenothiazine, is it? Hydroxyzine. Yeah, okay. Pain? Okay, so we'll go over all this. See, these are problems which are difficult to treat in cirrhosis. So symptom relief is important. Let's take fatigue. First, anemia is common, hypothyroidism is common, depression is common, hepatic encephalopathy, sleep apnea. Try and look for all these problems first. There are pharmacological interventions to treat fatigue, but not proven. Modafinil, I know, is available in India that has been tried for fatigue, okay? So try and correct what you can in these patients. So this is why they are fatigued. Peripheral features, so you spoke about muscle. So they've got reduced muscle strength that makes them more tired. They've got poor concentration, memory. We know central features associated with fatigue. And depression, social isolation is also a problem. And this interplay makes patients more fatigued. So you have to try and break the cycle somewhere. So generally, reverse what you can. So try and treat the etiology. If they've got hepatitis C fatigue, treat hepatitis C. They'll feel better. Treat anemia. Treat hypothyroidism. But sometimes you cannot reverse. So relieve what you cannot reverse. So sleep. Try and help them to sleep better. Pruritus. Try and treat the pruritus. We'll come into that in a bit. People feel tired and you're socially isolated, they tend to have more fatigue. Try and tell your patients' families to spend time with patients with cirrhosis. You know, more patients have symptoms, the more they sit by themselves, more depression, more fatigue. So avoid social isolation in these patients. Nutrition and exercise. So these are the ways you try and cope. Nutrition, exercise, avoid some social isolation. And patients complain that physicians are not interested in treating this. It's easy when we give them a drug. Try and explain to them, spend some time, I'll go with them, explain to them that you understand that they're fatigued, there are limitations what you can do, but this is what we're going to try, okay? So here's exercise, okay? So this is systematic review, baseline VO2, 17.4. Who's 50 years old, approximately? 50s, some? what should your VO2 be if you're 50 years old? So this, the higher it is, shows in better shape that you are, that you can take in oxygen. So what should a VO2? You're on the panel. You can give the microphone back now. Don't take the microphone. Just pretend it's your turn with the microphone. What should your VO2 be? You look like in your 30s. What should your VO2 be? So exercise, this is physiology. Okay, so at 50, it should be about 50. The athletes have a much higher than that. So in patients with cirrhosis who are aged about 50, VO2 is 17.4, which is the same VO2 of an 85-year-old. So patients with cirrhosis are really fatigued. Now, if you exercise them, you can increase VO2 and decrease their age. So their fatigue decreases. So try and get your patients to do some exercise, let them walk a little, ask somebody to walk with them. It's good for them, gets them out of social isolation, something to look forward to rather than sitting in their house or in a room by themselves. Get them to walk about, get them to lift small amount of weight. Even while sitting in the house, they can lift some weight. That will be helping their muscles. So exercise training. So this is what we know from all the studies of exercise in patients with cirrhosis. So resistance training, lifting some weights 2 days a week, aerobic activity 3 to 5 days per week for 30 minutes. VO2 increased, 6-minute exercise test, they could walk more, they felt better, muscle mass improved, portal pressure decreased. So take home message, one, make patients feel well, ask them to walk, give them some exercise, give them nutrition. All this is something that we don't typically take care of, but try and do that. And when health-related quality of life is measured, 6 showed significant improvement. So get them to exercise, they're going to feel better too. So to summarize, this is how you're going to manage fatigue. First, rule out other conditions. So anemia, hypothyroidism, sleep apnea, rule that out. Start an exercise program, repetition exercises. Don't give them long exercises to do because they feel tired and they won't. Short exercises because the muscle has to recover. Daytime somnolence, modafinil may be used. I don't use it except very occasionally. Important, listen to your patient, be empathetic. If they're itching, we'll talk about it. If you treat itching, it'll improve their sleep. And yoga seems to help. So try and get them to do some yoga too. All of that will help their fatigue. Then sleep. Remember, sleep apnea can masquerade as hepatic encephalopathy. There's even some thinking that this reversal of day-night rhythm was actually sleep apnea, obese patients who were somnolent, snoring at night and not sleeping, so they were sleeping during the day. So these were patients with cirrhosis and sleep apnea. That's simply because if patients are not obese, this day-night rhythm, you don't see that much of a change. Okay, so look for sleep apnea in these patients. So suggestions. Patient says, I don't sleep, try simple things. Try and treat cramps, pruritus, sleep apnea, that'll help. This is one thing we can do very easily. I don't like twice daily doses of lactulose diuretics. You go diuretic in the evening. Lasix is called Lasix because it lasted 6 hours. So if you give them Lasix at 8 o'clock in the night, till 2 in the morning, they're not sleeping. They don't. If you give them lactulose 3 times a day, then at night they're going to the bathroom. So try and make lactulose dose as a single dose at night so it works in the morning. Give diuretics in the morning so it works during the day. So that way patients will sleep better. Non-pharmacological, good sleep hygiene. Try and sleep at the same time. Don't nap in the afternoon. No caffeinated drinks in the evening. Again, these help patients. Safe drugs, zolpidem. Do you get zolpidem here? Melatonin? Zopiclone? Trazodone is very good. You spoke about patients with alcohol. The one which seems to work best for patients with alcohol-related sleep problems is trazodone. So trazodone is also a cheap drug. So that's for sleep. Then muscle cramps. Generally remember this. It's same for you. If some of you may be athletes, if you run a lot, if you run too much, especially if you're not trained, your muscle will cramp. So fatigue muscle is more likely to cramp, okay? And especially if it is cold. So generally tell them, if they're cramping at night, tell them not to be too active during the evening. Let them, whatever activity they want during early in the day, and try and rest towards evening. Make sure that they're covered well at night so that their limbs are warm. And someone said Plaquenil, baclofen has been tried. Pickle juice, this is very interesting. The neurologists have used it for almost 30 years for leg cramps. Take something sour. If the cramps are very severe, drink something sour. And this is a study which was done by Elliot Tapper. So when the juice is in your throat, the neurologist said maybe it's pH related, that when you change the pH, your cramps go away. But it is reflex. Even before it has gone down from the throat, the cramps can stop. So tell them, if they keep something sour, some achar juice at the side. If it's sour, drink something quickly. Reflex action, the cramps will decrease. So simple things to help patients, otherwise they won't sleep at night. Pruritus, huge problem again. Because of pruritus, they don't sleep, they're isolated, they don't want to come out if they're scratching all the time. So they get depressed, they're tired, they're not sleeping, their quality of life is not good, and you see patients, they scratch so much that their skin peels away. So they get self-mutilation, they cannot focus on anything because they're itching. And patients tell you it is really very difficult to manage with the itching. So how do you manage pruritus?
The first should rule out.
So you took the mic very quickly, so you're confident.
First, we should rule out any concomitant cause for pruritus, like if any intrahepatic or extrahepatic cholestasis or biliary obstruction
So if there's biliary obstruction, relieve it. I agree.
If it's not there, I will start from symptomatic treatment with hydroxygen. Plus, we'll use some local skin emollients to make the skin more supple.
Good.
And
do you want to do that first before hydroxyzine? I agree with you. Do you want to do that first before hydroxyzine?
Yes.
Yeah, it's good. Always do that. And then if that doesn't work, hydroxyzine. If that doesn't work, what do you do? Who's had patients with pruritus, intractable pruritus? No one? What do you do?
We proceed with cholestyramine, naltrexone.
Good, very
rifampin.
good. Naltrexone, good. Yes.
Sir, in cirrhosis, cholestyramine is better, and
very
few
good.
studies also showed naltrexone.
Very good. So try all these stepwise. I agree. So mild itching, no need of pharmacological treatment. Try something which they can apply. Remember, yeah. So but not first. So initially simple. Always start simple. Ask them to apply something to the skin. Something cold helps. Remember, if you put something warm, if you have a hot bath, your skin vasodilates, which increases the pruritus. So ask them to avoid hot bath. Ask them to take, if they're itching in a place, cold towel, apply it locally. Simple things help. If that doesn't help, try a moisturizer. That doesn't help, try a bile acid binder. That doesn't help, then we go to rifampin. What's the dose you use?
Rifampin 150 to 300 mg.
Yeah, start with 150. Always start simple. Start with 150, then gradually go up. I agree. So rifampin is a good drug, going up to 450. Good. Naltrexone, good. I don't typically use it. Get a little hypotension. Sertraline is a very good drug. I like sertraline. Why? Why do I like sertraline? It helps pruritus. What else?
It also treats anxiety, depression because it
Correct,
is SSRI.
which these patients have a huge problem with. So this helps manage the pruritus and helps manage their depression too. So it's a good combination that we can use. If that doesn't work, then it's only experimental treatment. You know, Mars and all have been tried. And then there's liver transplantation. So often we have to consider Mars, but it's very difficult to do. So hopefully patients manage by, with. So once you get to sertraline and all, you're reaching towards the end here. So that's how you manage pruritus. And last of all, pain. Pain is another big problem. Stepwise management. What's the first step? Give the mic away quickly.
So non-steroidal anti-inflammatory like paracetamol you can use.
Always be simple. Start with that first. What medications would you use?
Say paracetamol, and if needed, then next NSAID can be used, or then opiates.
Do you want to know whether it is somatic pain or neuropathic pain? Does it make a difference in treatment?
Yes, if in neuropathic pain, we have to add neuromodulators. We have to add.
Correct. So from the type of pain, try and get some idea of what they have. So first we try and treat whatever cause it is. If you've treated the cause, the pain will go away, hopefully. Somatic pain, massage, local measures first. Again, paracetamol, less than 2 grams per day. If paracetamol doesn't work, remember these are decompensated, so you cannot use non-steroidals. Then what are you going to use?
After paracetamol, non-steroidal, and then opioids can give low doses.
Opioids. So we're reaching opioids. So generally, opioids, if they might also have renal dysfunction, so then there's a concern. Liver's not working, kidneys are not working, so opioids will last forever, worsening hepatic encephalopathy. So if the GFR is low, hydromorphone is better, okay? So consider that. Neuropathic pain, because they have neuropathic pain, especially if they've got diabetes and all too, but cirrhosis by itself causes a neuropathic type of pain. That's when you use gabapentin, I know is available. Is pregabalin available? Tricyclics, good for these patients, okay? So try simple here. Caution, no non-steroidals, tramadol, no oxycodone. Someone said tramadol, I think was that in the last talk? Why not tramadol in cirrhosis? Because high risk of addiction with tramadol. They get dependent very quickly on tramadol and they get addicted. So no tramadol, no oxycodone, no non-steroidals in these patients. So clear how you manage pain? Okay. So summarize, how do you manage pain? Local before systemic therapy. Always start simple. No non-steroidals. Opiates only if absolutely needed. This is my rule of thumb. If you're using opiates, use half the dose of whatever you're using, twice the interval. Start first. Start small dose, spread out the interval, and then gradually increase. Okay, so take-home messages. Symptom relief, huge problem, not only for the patient, but for the caregiver too. So be kind. Tell, patients need someone whom they can communicate it with. If you have poor quality of life, they have worse outcomes. So I think empathy for the patient is a helpful first step. At least listen to what they have to say. Don't dismiss them and say, no, there's nothing I can do. At least try and listen to them. Have an honest discussion regarding expectations. I tell them there's some things I can do, some things I cannot do, but I'm going to try. Reverse what you can. And if you cannot reverse it, try and relieve what you cannot reverse. Most of all, be there for your patient and help them cope with their symptoms. Okay. Thank you.
Thank you, sir. Thank you for a very informative talk.
So just wanted to know if like pruritus, you told management of cholestatic pruritus, but if most of the patients were coming with pruritus and alkaline phosphatase and GGTs are normal. So like if pruritus is not like non-cholestatic pruritus, the management, how will management will differ for those patients?
Yeah, so good. So the question for cholestasis, can you get it without cholestasis? And we know with liver disease, we can get it without cholestasis. We can get that. And how does the management differ? The only difference is you start with a simple treatment. They are much easier to manage than if they have cholestasis. So we typically don't need to go much higher in these patients. Also remember there's something which is called psychogenic pruritus. So once patients start itching, they keep scratching because it's the brain. I forget what the switch is called in the brain. Once it starts firing, it keeps firing. That's called psychogenic pruritus, and that's where tricyclics will help.
Sir, any insight, any insight regarding a molecule by the name of tapentadol that is a congener of tramadol? It has been set for chronic pains without any hepatic or renal involvement or dysfunction.
Don't know.
Thank you, sir. Thank you.
Sir, any role of BCA for cramps? Branch chain amino acids.
For which one?
For cramps, BCA, sir. Branch chain amino acids.
I don't know. You know, albumin, someone said albumin has been tried. It helps for a short period of time. Branch chain amino acids, I don't know. Cramps is very difficult to treat. So none of these studies which have done short started with the simple things first. Avoid too much exertion, keep the muscle warm at night. Those are the simple things more likely to work. Plaquenil works. Plaquenil is a good drug, but remember liver disease, you have to be a little more careful and you have to check the eyes too with Plaquenil. So.
Thank you, sir. Thank you, esteemed sir.
Sir, one more question, sir. Sir, I want to ask, sir, any role of carnitine, zinc carnitine in cramps? Cramps I've studied some study about carnitine
like
also.
I said, everyone tries small amounts. I showed you the list of studies that have been done, all small number of patients. And this is publication bias. So 6 patients, carnitine, all lived happily ever after. They published it. The 20 patients with carnitine, when nothing happened, no one publishes that. So anytime you get a small study, it's not, be very suspicious of the results, because if it was really so good, you'll get multiple studies with larger number of patients.
So one more question, sir. So UDCA for cholestasis of chronic liver disease, sir. Is it
Yes.
helpful?
So the question is, does ursodeoxycholic acid help the pruritus in these patients? Yeah, it has been tried, but it has always been tried in association with something. Remember, patients on ursodeoxycholic acid, as the liver disease progresses, can develop itching too. That's one. The problem is obeticholic acid. Is obeticholic acid available here? What's the biggest side effect? Pruritus. So we know there's a problem with these drugs too.
Thank you, sir. Thank you. Thanks the panel for this discussion. I would now request the panelist and the speaker to take their seats in the audience. Moving on to the next session that we have, the 5th case for the evening, that is incidental HbSAg positivity in pregnancy. I would like to invite the chairpersons for the session, Dr. Rohit Gupta, sir, Senior Consultant Gastroenterologist, Foundation for Research and Education in Gastroenterology and Endoscopy, Prayagraj. We have only one chairperson for the session. So I would like to request Rohit Gupta, sir, to call.
Dr. Sanjay Pandey is a senior consultant physician from Varanasi. Dr. G.P. Rai is a consultant gastroenterologist practicing in Varanasi. and Dr. Madhukar Rai. He is ex-professor and head of the department, IMS BHU, presently at Heritage Hospital, Varanasi. And I call upon Dr. V.K. Dikshit, sir, to I first thank you for inviting us, and then he will talk on incidental HBsAg positivity in pregnancy approach.
Thank you, Chairperson and panelists. This is, I think, one of the very common subject. Many of you, or I think everyone has got this type of problem. Ki patient, pregnant female, she walks in your clinic and she is terribly upset that I have got hepatitis B positive. And then what to do? So I will start with a case prototype. A 25-year female patient without any major illnesses. She is primary, 4th month of gestation, referred from ops department in your OPD in view of the hepatitis B positive, and there is deranged LFT as mentioned. Patient is otherwise asymptomatic, no history of any jaundice in the previous years, there is no history of any jaundice in the family also, and there is no history of any addiction, alcohol, etc. So I would ask Dr. Sanjay Pandey, now what do you do actually such patient? What next you do?
We'll get the routine tests done, a CBC done, PT-INR test done, the liver function test done, and then we will see this is a hepatitis B positive patient. So we'll take up hepatitis B surface antigen antibodies also, and core antibodies also, test done, and we'll see the viral load. What is the viral load? HBV DNA test done. We'll take ultrasound and other measures to find out the status of the patient, current status.
Thank you, thank you. So the same thing was done. The transaminases were just SGPT 54, SGOT 47, ALP 148, protein was 6.4, albumin with 3.7, bilirubin was 1.2, with direct with 0.4, and renal function tests, they were normal. Hepatitis B was reactive, and hepatitis C and HIV, they were non-reactive, and PT-INR was also normal. So these are the few actually things which comes into the mind of the patient. Ki how do I get it? Doctor, हमें तो कभी कुछ हुआ नहीं था. Why I got it? This hepatitis B positive. What further investigation should I get it done? Will it interfere with my normal course of the pregnancy and effect on my baby? And what medicine I put it? So I will discuss in the subsequent slide these things. Now, as far as the disease burden is concerned, in Asia, it is 8 to 10% of the population is still chronically infected with the hepatitis B, and up to 50% of the new cases are due to perinatal transmission. So it means, in the particularly Southeast Asia, still the horizontal transmission considered is the main mode of the transmission. In developed countries, majority of new cases are horizontal transmission, and about 15 to 45% patient they died of the cirrhosis or complication of the hepatitis B related disease. So now regarding the mode of transmission, so I will ask Dr. G.P. Roy, now what are the different modes of transmission in patient who is having hepatitis B positive, and what is the risk of MTCT?
Sir, patient should be tested for HBV viral load as well as the HBAG status, anti-HBAG, and if viral load is very high, then risk of transmission is very high. If patient is HBAG positive, then also risk of transmission is very high. Other risk factor which usually increases the transmission from mother to fetus is that if patient is having preterm labor and premature rupture of membrane as well as the procedure like amniocentesis. These factors usually increases the risk of transmission from mother to fetus. So main two factors are there, high viral loads as well as the HBAG status of the patient. If HBAG positive, viral load is high, risk of transmission is very high.
Thank you. So any body fluid actually, but exposure to the viral laden serum is the most efficient mode of transmission. It could be perinatal, it could be horizontal transmission, it could be the sexual, or it could be parental. So these are the risk factors. Well, the risk factor we can broadly divide into the viral factors, host or maternal factors. Now coming to the viral factor, this is hepatitis E antigen is one of the considered the secretory protein which is immune modulative function, and it index of the active viral replication. So once HB is positive, it means the patient is having the viral replication phase. So maternal HBE antigen, this filtered through the placenta. So 70% of the neonates positive at birth, only 10% infected. And maternal HBE disappear by 6 to 12 months if no hepatitis viremia persists. So detectable hepatitis DNA, most important predictor of the immunosuppressive failure. So viral factor is one of the important, HBE, as I said, is one of the important. The mechanism of the actually high rate of infectivity in HBE positive patient is, this correlates with the high maternal viremia, low Ig anti-HBC in HBE positive patient, it means it is more transmission. Maternal HBEG interfere with the T cell recognition and telogens and make newborn immunological tolerant. Surface antigen is considered another marker which has got a maternal prenatal HbA1c titer higher than 1:2, more than 2,500, strongly correlated with the hepatitis surface antigen positivity in cord blood. So since hepatitis surface antigen titer has been replaced by the HBV DNA as the key predictor, so now it has only a historical importance. Otherwise, before the DNA, we used to give a lot of importance to surface antigen quantification. So mothers with the occult hepatitis B infection, low level of the perinatal transmission. So I would ask Professor Rai, what are the other maternal factors actually which are responsible for the mode of transmission in these patients? Dr. Madkar? Okay. Yes, GP.
Sir, basically the transmission is can occur during the pregnancy, at the time of delivery, as well as after delivery. But most transmission usually occurs during the time of delivery. And other factors that already increases the chance of transmission as viral load as well as the HBAG status of the patient. If any previous child is having HBAG positive patient in spite of immunoprophylaxis, that also increases the chance of transmission from mother to fetus.
Yeah, thank you. So if you see actually DNA level and risk of the transmission, there are various studies which have been published, but there are a few important ones. One study from Taiwan or Eastern China, Taiwan population, Australian population, and Chinese population. And what they have observed basically, if the person is having replicative phase, means there is a more chances of the transmission of the hepatitis B to the child. Now, what regarding the genotype? Now, hepatitis B genotype and risk of transmission. Now, HBV genotype in perinatal transmission, there are conflicting results. One Japanese study says genotype C and perinatal transmission is more compared with the genotype B, D or A. China Asian population genotype.
Sir, एक question था कि in case the patient is hepatitis B positive, mother, and E is also positive, in a resource poor setting, is it necessary to do a HBV viral DNA also? Because
viral DNA is considered the gold standard now.
That's fine,
Like,
but suppose E is also positive.
Yeah.
Do we need to do it? Because there is a risk of transmission if E is positive.
There will be risk of transmission in both actually, but it will be less with the E antigen negative, but the high viral DNA. And if both are positive, then definitely it's more.
And both the conditions, we are going to take the same precautionary measures as the patient of hepatitis B. We have to give antibodies at the time of birth. And so what's the fun of doing all these costly investigation in a situation like ours?
Sir, basically, if patient is having hepatitis B positive and she is having HBAG antigen positive, then we have to do immunoprophylaxis in any child during delivery. But if patient is having high viral load as well as the HBAG positive, then we have to keep patients on oral medication, antiviral drugs like tenofovir. Tenofovir as well as the immunoprophylaxis both are required to decrease the chance of transmission. Otherwise, immunoprophylaxis only decreases the chance of transmission, not 100%. 10% patient may have HBAG positive child may have if patient is having high viral load and we have not given the oral medication. Yes, we have to need to mother with tenofovir if viral load is very high and patient is HBAG positive. Cutoff level is usually more than 2 lakh international unit per ml or more than 10 to the power 6 to 10 to the power 8 copies per ml in third trimester.
Particularly Southeast considering it does not have much of the value. It is irrespective whether it is a genotype A or B or C, whatever. So it's not considered very significant. Now, regarding the escape mutant and the risk of transmission, the mutants of the S gene, either vaccine-induced or spontaneously, they are not responsible for vaccine failure and risk of the transmission. The role of pre-core and basal core mutations, perinatal, has not been fully explored. Now, regarding the maternal factor, as I have already discussed, with GP Rai has told, the maternal factor we can divide like a prolonged uterine contraction, or there is a threatened preterm labor, or there is a linear correlation between the prolonged first stage of labor, is more than 9 hours, and a cord blood hepatitis surface antigen level. So if you see this table, the transmission risk at the various stages. Now, it is the highest with the intrapartum, around 40%, less with the antepartum, around 10%, and it is the minimal with the postpartum. So person-to-person transmission is quite variable. So HPV transmission, antepartum, what could be the stage where the antepartum stage, there could be hepatitis B transmission. If there is a male germline, maternal oocyte in the early embryonic phase, maternal peripheral blood mononuclear cells, cellular transfer, or partial placental linkage at the time of threatened preterm labor, or amniocentesis. Intrapartum stage hepatitis B transmission, as I said, is the prolonged labor. First stage of labor is more than 9 hours. Trauma from the instrumentation, or the threatened preterm labor, or there is a direct contact with the infected genital tracts, and maternal fetal microtransfusion. Hepatitis B surface antigen detected in 55 to 98% of the vaginal epithelial cells, 26% in amniotic fluid, and 96% in the vaginal fluid. That simply shows that during the vaginal phase or delivery, this is the highest actually risk during the intrapartum stage. Prolonged first stage, more than 9 hours, it is a linear association has been seen between the incidence of the hepatitis surface antigen cord blood and the duration of the first stage of labor. Postpartum stage, the breast milk is around 72%, hepatitis surface antigen is positive. Gastric liver is around 90% of hepatitis B positivity. So breastfeeding infants not at all risk of transmission, then formula bed baby if they are adequately vaccinated. This is important. That's why all the newborn, the first and foremost thing is to give the vaccination, active and passive. Breastfeeding not a risk factor for the transmission, as has been shown in this table, and particularly it has been shown that the formula fed, they have more chances of the risk. Breastfeeding is not contraindication, a baby is adequately vaccinated. And genetic factor also has been highlighted, but they don't have much of the importance. So what further tests now required, Dr. Sanjay Pandey? Now you have done routine testing, you did ultrasound, you did this thing. Now any specific tests you required this stage now?
We need to follow the antibody against the surface antigen, the core antigen, hepatitis E, and HBV DNA we need to find out. Because if the viral load is low, we need to have give antiviral agents to the mother beforehand. So in the about 24 to 28 weeks, we need to repeat the test to find out if the viral load is increasing or not.
Okay. So actually, if you require, now what you have to do, you should know the hepatitis E antigen status or anti-HB status, quantitative DNA, role of quantitative surface antigen. Now it doesn't have much of the importance, but still people do. And this quantitative DNA at 28 to 32 weeks is desirable. Fibroscan usually not recommended. And if you see this patient, the E was done, which was negative. Anti-HB, it was positive. And the DNA was not very high. It was 247 international units per liter in this patient. So what are the treatment options available, Dr. G.P. Rai, for this patient?
Sir, this patient has very less viral load and LFT is just only mild transaminitis and HBAG negative and anti-HBAG positive. So as far as the medical treatment of the patient is concerned, no antiviral treatment is required. Only the immunoprophylaxis of the newborn at the time of delivery, that is in form of active and passive immunization, is required to prevent the vertical transmission.
Yes.
Both active and passive, even if the viral load is low, there are some studies which say that even if you vaccinate the routine vaccination, that is good enough.
No, the current CDC guidelines recommend that as active and passive immunization should be done simultaneously within 12 hours of delivery to all patients.
Okay. So What we do the antepartum stage also you can do the HBIIG and nucleoside or nucleotide analog, but not in this patient because the viral load was very low and HB is also negative. But there have been studies actually where the people have used this HBIG along with the hepatitis B vaccine in the mother, and they have shown that there is some decrease in the CHB transmission. Now, role of the nucleoside and nucleotide analog. Now, if you see the safety profile of the nucleoside analog during the pregnancy, the talbubidine and tenofovir, they are considered to be good. They come in the B group as compared to the lamivudine, entecavir or atfovir. So nowadays we prefer actually the tenofovir as the first drug if you have a high viremia. The role of the nukes actually preventing the perinatal transmission, the tenofovir may be appropriate option who might need for continuing therapy for long term. And there are few reports of the use of entecavir and atfovir in pregnancy, but they're generally not recommended. Nukes in hepatitis B carrier mothers from 28 weeks of gestation may interrupt MTCT of hepatitis B efficiently, and it is safe and more efficient than the hepatitis B immunoglobulins in interrupting the MTCT. And hepatitis B more effective in preventing transmission if maternal viral load is reduced to less than 10 to the power 6 copies per ml by lamivudine treatment. Now, at intervention at the peripartum stage, what we have to do, you have to choose between whether you want to have a normal vaginal delivery or you want to do the elective cesarean section. Dr. Matkar, any thought about it?
I would try to review this thing but what I think is like HIV transmission, which is occurring during the antepartum period, the least the traumatic pregnancy the better the outcome has to be. So maybe I would not like to apply a forceps. If it is normal, it is fine. I would not like to apply a forceps or extract the delivery or delay the delivery. Maybe I would prefer for a LSCS.
So role of actually elective cesarean section in preventing perinatal transmission, there was a study actually where they compared from vaginal delivery, the elective cesarean section, the sample size was adequate, and they have found that infant hepatitis B infection was less in the elective cesarean section, is around 1.4% than the vaginal delivery, which is 3.4%. And if you have to do the cesarean section in the urgent stage, then definitely the infection is much more. So there is a significantly lower rate of the vertical transmission of hepatitis B infection to infants delivered by the cesarean section, elective, compared with the vaginal delivery. And elective cesarean for a hepatitis E positive mother with pre-delivery levels of DNA more than 1 to 10 to the power 6 could reduce the vertical transmission. The intervention at the postpartum stage, the hepatitis B vaccine or HBIG. So Dr. Sanjay Pandey, what you will prefer?
Already told by Dr. Rai, both are preferred. HBIG for immediate cover and HBV vaccine for the routine. So both should be done.
Yeah. So actually same thing has been highlighted in this meta-analysis. I will not go into detail, it is a little pretty busy slide. And they have only simply shows that this vaccination and the HBIG, they both should be given at the time of the birth. And now what is the CDC recommendation of the new vaccination, doctors? GP.
CDC recommend hepatitis B immunoglobulin 0.5 ml IM within 12 hours of delivery and hepatitis B vaccine 0.5 ml IM at separate site apart from the hepatitis B immunoglobulin within 12 hours. And the second and third doses can be given 1 month later and 1 to 2 months later, and third dose at the 6 to 15 or 6 to 18 months after delivery.
Yeah. So there is no doubt that we should give the both HBIG and HBG at the same time within 12 hours. So if you see, this is just a flow diagram, flow chart. Now, if a pregnant female, she comes to you with a positive hepatitis B surface antigen, what you do, you simply first see whether HBE is negative or positive. Suppose patient is high, or there is a previous child failed HBIG vaccination, then directly you can start. These are considered as a high risk for the MTCT, and patient should be put on the 12 drugs, antiviral. But if the HBDN is less than 2 lakhs international unit, previous child has been successfully vaccinated, You can wait because there is a low risk of the amplicity, and all infants should receive the HBIG and vaccine within 12 hours. And those patients who are having HB positive but the less DNA, again, there could be high risk and you could put the patient with the drug. But those who have got hepatitis E antigen but the less DNA, they have the low risk and they can be just observed and only the infant can be vaccinated. Duration of the treatment? What is the likely duration, Dr. GP?
Most of the guidelines recommend that duration of treatment should be at least 1 month after postpartum, but it is seen that at least 25% of the patients develop post-delivery flare of the hepatitis B within 6 months after delivery. But still prolongation of the treatment does not decrease the flare, so most guidelines recommend only up to 4 weeks after the delivery. Treatment should be continued only for prophylaxis.
Yeah. So it's agreed actually, and the INASL guidelines also say the same thing. We should continue the treatment at least for 3 months. So take home message, friends, the surface antigen positive mothers should be evaluated for transmission risk. The infant should receive the immunoprophylaxis. Nuke during the 3rd trimester in selected patient who have got a high DNA and HB positive. Breastfeeding is not a contraindication, and elective cesarean section may be useful in selected patient. Thank you very much. For sake of time, we just end here.
Thank you, sir. Any questions from the panel?
I would like to ask one question, sir. As a few patients came in first trimester within 1 month after getting pregnancy, with reports that LFT, HBAG, anti-HBAG as well as the viral load. Suppose that at that time viral load is not up to the standard to start the antiviral treatment. Can we repeat viral load in 3rd trimester, or should we leave the antiviral drugs throughout the pregnancy?
You can repeat.
Any other question?
Which we can start the treatment with tenofovir.
Treatment?
Yeah. Suppose the patient mother has got a high titer, and so is it? What is the chance of transmission if I start at the the beginning of the 3rd trimester or at the beginning of the 2nd trimester?
Generally, the recommendation is that we should start at the 3rd trimester. So usually we is starting from 7th month onwards, actually. 7th, 8th, and 9th, and then it continues up to the delivery 3 months after that.
So this three months period is sufficient to bring down the viral load.
Thank you, sir. Thank you, esteemed panel. I would like to end this session, and I would request all the dignitaries to get their seats back in the audience. So for the final session of the day, I would like to invite the chairpersons for the session. Professor Dr. V.K. Dikshit, sir, Professor and Head of Department, Department of Gastroenterology, IMS BHU, and Dr. Anurag Tiwari, sir, Assistant Professor, Department of Gastroenterology, IMS BHU. And I would request the chairpersons to call upon the stage the panelist for the session. We have only one panelist for this session.
So I would like to call Dr. Vinod Kumar also as a panelist. Dr. Ravikant. Dr. Ravikant, please come. Yes, sir. Yes, sir. Please go ahead.
Okay, so my last talk will be on decompensated cirrhosis. So I'm going to start off with questions, but I'll give you the answers only at the very end, okay? So patient is on spironolactone. Patient has ascites, 100 milligrams spironolactone, 40 of furosemide, uncontrolled. Urine sodium, 100 milliequivalents. Increase spironolactone to 200, furosemide to 80. Increase both. No diuretic change, say enough. Let's do paracentesis. Sodium compliance. Okay. What do you think?
Same, sir.
Safety precautions before large volume paracentesis. INR less than 1.5, platelets 100, limit to 5, limit to 10, albumin 6 to 8 grams per liter removed.
E, sir.
Good. True or false? Hepatorenal. Maybe we can ask that. Most common cause of AKI, hepatorenal.
No, sir.
Classified as type 1 and 2.
Yes.
Urine sodium more than 30.
Less than 20, sir. Or 10.
Marked arterial or vasoconstriction in extra.
Vasodilation.
Albumin and midodrine very effective.
Effective?
Not very effective. Okay. So for those of you who are not familiar with the Bristol scale, I have a picture of the Bristol scale on the right. So patient is on lactulose for hepatic encephalopathy. So when will you increase the dose? 4 type 1 Bristol with encephalopathy. B, 1 type 7 with no encephalopathy. Or let's see, 4 type 1 Bristol with encephalopathy. Who will increase lactulose? Okay. 1 type 7, only 1. Type 7 Bristol, no encephalopathy. Remember recommendations? 2 to 3, 3 to 4 semi-formed bowel movements. Patient has only 1 type 7, no encephalopathy. Wants to increase lactulose? No. 2 type 5 with encephalopathy. Wants to increase. 1 type 6, no encephalopathy. No stools, but no encephalopathy. What do you think? Just true or false? A, true.
There are 4 stools, right, sir? 4 stool type 1. Frequency is 4 and
4
stool
type
type
1
is type 1.
and has encephalopathy. Will you increase lactulose?
No, sir.
Okay. B?
Yes, I'll increase.
Okay. So we'll go over this again. Side effects of lactulose. Hyperkalemia. So what? Hypokalemia. Hypernatremia. Hyponatremia. Abdominal bloating. Yeah. So remember, these are all the problems that we should look for, okay? So let's go over basics again, especially for the physicians. We'll go over pathophysiology. We'll talk very little about bleeding, spend more time on ascites, hepatic encephalopathy, and then some take-home messages. Okay, so this is why you get problems with cirrhosis. There is increased intrahepatic resistance. That is because of fibrosis and also vascular. That increases portal pressure. Also, you have increased portal blood flow. So the combination of increased flow and increased resistance. Remember, pressure equals flow times resistance. So flow is increased, resistance is increased, so portal pressure increases. Now, as a result of portal pressure increase, portosystemic collaterals develop. You have varices, and varices can bleed. So that's complication number 1, decompensation. With elevated portal pressure, renal retention of sodium, you get ascites. And with portosystemic collaterals and hepatic dysfunction, you get hepatic encephalopathy. So these are the 3 decompensating features. So let's go over bleeding first. Small varices, no varices to small varices, about 7 to 8% per year. Small varices to large varices, another 7 to 8% per year. So if they're decompensated, if they're drinking, that risk is going to be higher. So why do varices bleed? You want to take that? Because they're large, because wall tension increases, high portal pressure, or because the varix wall is thin?
So because of high portal pressures.
I think you know from the previous time not to touch the microphone, right? So I can see you, the moment I ask a question, you put your hand like this. So, okay. So maybe you can answer. You can show you're brave. You can take the microphone.
Because of high portal pressure.
So if the portal pressure is high and the vessel wall is thick, will it explode?
Yes, sir.
If the wall is thick and the pressure is high, will the varix bleed?
So if the wall is thin, then it will be more prone to bleed.
So is pressure alone important? Which is the most important here? Only one.
Tension.
If the diameter is large and the pressure is low, will it bleed?
Wall tension is important.
Who said that? Very good. So wall tension, so it's a combination of everything. So wall tension equals?
Pressure upon the distance or the radius of the...
Pressure, radius. So higher the pressure, more tension. So you're right, pressure, but not alone. Next, diameter. So it is fourth of the diameter. So as the wall tension increases, as the diameter increases, and inversely proportional to wall thickness. So remember this. Take a balloon. Varix is like a balloon bursting. You blow the balloon up, what happens? Pressure in the balloon is increasing. So it is the difference in pressure inside of the balloon and the outside which makes a difference. So if you blow a balloon in a high pressure chamber, no matter how much you blow it, it won't explode because the gradient is important. Okay? So the transmural pressure gradient is important. As the diameter varix becomes bigger, like a balloon, diameter increases and the wall thickness decreases. The varix becomes thin. So a big varix in the stomach, less likely to bleed because intra-abdominal pressure is positive. So the gradient is low. Okay? And the wall thickness is more. Whereas in the esophagus, lower end of the esophagus, unsupported, it has no support, so the wall is thin. Thoracic pressure is negative. So transmural pressure is high. Okay, so they bleed because of increase in wall tension. Typically they bleed in the lower third of the esophagus. So your treatment options for bleeding will go out only very briefly. You can have pharmacological treatment, you can have ligation, and you can have portosystemic shunts, and they act on different sites. So again, resistance, high pressure, increased portal flow. So you use beta blockers, Planck-Nick vasoconstrictors. They will increase Planck-Nick resistance, so that will decrease portal flow and that will decrease portal pressure. If you have variceal band ligation, that will work directly on the varices and obliterate the varices. It doesn't do anything for pressure. Or you have tips or surgical shunts, they decrease resistance to portal flow and that decreases portal pressure. So this is how they act. But for the physicians at the back, don't worry about endoscopy and tips, we only worry about beta blockers. And I think I had a question in the previous talk on beta blockers. If possible, it's difficult, monitor heart rate and blood pressure, carvedilol or long-acting agents, try nadolol or propranolol, administer once daily in the evening. Risk of bleeding is highest at night and early morning, cover them through the night. Target resting heart rate, 55 to 60 beats per minute or a 25% reduction. So that's what you're going to aim for. So that is easy. Now ascites, little more difficult, but more of a problem that you're going to see as physicians. So the cause of ascites, worldwide cirrhosis is the most common. Then you have cardiac failure, combination of cirrhosis and cardiac failure, malignant ascites, other causes. But remember, it depends on the hospital you're working in. If you're working in a cancer hospital, probably 50-60% of ascites will be cancer. Hospital, or if you're in a general hospital with a lot of infection, there'll be much more patients with cirrhosis. So the percentage will change, but still cirrhosis is generally the most common cause. So we went over pathophysiology of bleeding. Let's go over pathophysiology of ascites. This is important to understand if you want to know how to treat. So increased resistance, so increased pressure, decrease in resistance of vasodilatation. Remember, patients with cirrhosis, vasodilated, high pulse pressure, low systolic pressure. So the same vascular space is now expanded. So the volume of blood is now flowing through a more expanded vascular space. So the kidney thinks there is less blood volume. So anytime this kidney sees less blood volume or a decrease in the effective arterial blood volume, it activates neurohumoral systems, which are renin-angiotensin and aldosterone. So renin-angiotensin aldosterone, the work is to retain sodium and water, and that causes ascites. So this is how you get ascites. So when you get a patient with ascites, I told you 80% is going to be cirrhosis. So the first thing you want to do is measure the albumin in serum, measure the albumin in acidic fluid. The difference is the gradient. That will tell you where the ascites is coming from. So if it is greater than 1.1, it tells you it is leaking out of the liver. Okay, so it can leak out of the liver either because of cirrhosis or because of cardiac disease. So cirrhosis is more chronic. So with time, the capillaries, the sinusoids get a little thick, so less protein comes out. So high gradient, low protein is liver disease, cirrhosis. High gradient, high protein, this means not enough time for the sinusoids to get capillarized, so they are still leaky, proteins are still leaking out, and so you get cardiac cause of ascites. But if the gradient is low, then we know the fluid is coming from the peritoneum. That means the protein is high. And peritoneal disease generally consider only two. There are other causes, but generally considered two. It's tuberculosis or malignancy. Okay? So for physicians, this is going to be a workup for patients with ascites. So whom will you do a diagnostic paracentesis on? Everyone. But also, if a patient has cirrhosis and gets admitted to hospital, you always want to know, was this infection which was the cause? So on admission, features of SPP, unexplained encephalopathy, renal dysfunction, or you cannot explain why they're getting worse, make sure you have a diagnostic paracentesis because you want to rule out SPP. So the only contraindication is an uncooperative patient. Don't worry about platelets and INR. You don't require them before outpatient paracentesis. Okay. So now the patient has ascites, and the liver is getting worse. So the liver gets worse, arteriolar resistance decreases, they get even more vasodilated, further decrease in the effective arterial blood volume, more activation of the neurohumoral systems, more sodium and water retention, and they get refractory ascites. Even worsening of the liver disease, then you get renal vasoconstriction, because I told you activation of neurohumoral systems, and that causes hepatorenal syndrome. So this is the pathophysiology of ascites, refractory ascites, and hepatorenal syndrome. So to summarize, patients are vasodilated, kidney senses this as less blood volume, so it activates neurohumoral systems, which retain sodium, so you get ascites, renal vasoconstriction, so you get hepatorenal syndrome, and retains water because of ADH, and they get hyponatremia. So we'll focus only on treatment of ascites today. So patient has come in, get acidic fluid for protein and serum acidic fluid albumin gradient, because you want to know, is this cirrhosis or not? And you may want to get cell counts because you want to know, have they got SPP? That's all the investigation that you need. If the gradient is high, then you might look for other causes. But otherwise, generally, just protein and cell count is enough for your first diagnostic, except if your suspicion of tuberculosis or malignancy is high. So how do you treat? So we said the sodium and water retention. So you can use diuretics and sodium restriction. That will decrease sodium and water retention, and that decreases the ascites. If that doesn't work, large volume paracentesis and albumin. Albumin increases the effect of arterial blood volume, and large volume paracentesis removes the ascites. Or you can use TIPS, increases the effect of arterial blood volume, decreases sinusoidal pressure, and so decreases the ascites. Okay, so these are the principles. We'll focus only on management of uncomplicated ascites. So physicians, you can manage uncomplicated ascites. Complicated ascites should go to the hepatologist. What do we mean by uncomplicated? Responsive to diuretics, no infection, no renal dysfunction. So start with sodium restriction. It's effective in small number of patients. When do you suspect that? Urine sodium is high and not much ascites. I like urine sodium. It's a very cheap test. Tells me a lot, and we'll show you later how it helps you. Diuretics start off with spironolactone. You can have monotherapy. Dose of spironolactone that you use, how much spironolactone should you use? Anil? How much spironolactone will you use? Dose range?
Starting from 50 milligram, raising it up to 200 milligram.
Up to?
200.
200, okay. Anyone goes higher than that?
400 milligrams.
Who uses 400? Who has ever used 400? So that's the problem. You know, people write something, refractory ascites is 400 of spironolactone and 160. And if you ask the people who wrote it, they said, we never used, we just thought beyond that, it doesn't work. It is impossible to get a patient on higher doses. If you go beyond 200, generally, then they start getting hyperkalemia and they get problems. If you go high on the dose of furosemide, they get renal problems. So you're absolutely right. About 200 is generally okay with spironolactone. The combination is better but requires more monitoring. Okay. So uncomplicated ascites, restrict sodium, 2 grams. South Indian diet has more sodium. Why is that? Now I don't know now because diets are changing in India, but traditional South Indian diet has more sodium. Why? What do we have in South India more than? We use more pickle and chutneys, which are high in sodium. So fluid restriction, don't restrict fluid. Remember patients with cirrhosis, I told you, poor quality of life. They're already miserable. They're not sleeping. They need some water, let them have water, don't worry. So don't restrict fluid except when they get hyponatremic, because fluid restriction has to be very severe. How much will you restrict fluid?
If the patient is sticking to low sodium diet, we do not require fluid restriction.
I agree. If they get hyponatremic?
Then we can restrict up to 1.5 to 2 liters.
How much?
1.5 liters.
Not more than that.
Usually
if you want to increase the sodium. So first of all, fluid restriction does not really increase sodium, it prevents it from getting lower, okay? So if you strictly want to restrict sodium, restrict fluid, how much should you restrict it to? What is the rule? So physicians, you should know this because this is what you know. So if you want to restrict fluid, it is urine output minus 500. That's very difficult, you know. So if you're restricting fluid, remember we're going to 1,000 or less, which is very difficult for patients. So try and avoid fluid restriction in patients. Your goal of treatment is negative sodium balance. They're taking in 2 grams, you need to get rid of 2 grams and some more in the urine. So 2 grams in urine is 90 milliequivalents. The problem is they need protein, and protein foods have sodium, okay? So here we start off. Spironolactone, 100 to 200, furosemide, 40 to 80. How much do you want them to lose?
Weight loss would be, sir, 0.5 kg if they're 0.5 kg per day if they are having a severe ascites, or weight, or if there is no pedal edema, if with pedal edema, I'll go up to 1 kg.
Sure, good. So 0.5 without pedal edema, 1 without. But do you want to see this in the first week, second week, third week? When do you want to see this? So when will you adjust the dose again?
So I think every third day I would like to see that.
So typically, remember spironolactone. So patient has not been on spironolactone, you're starting spironolactone. It takes about 5 days to work. So in the first week, if you lose even 1 kilogram in the first week, I think you're doing okay. So don't get too worried about changing dose in the first week. It is then the spironolactone is going to start working into the second week. Then you have to monitor that, okay? So we'll go. So increased diuretics if weight loss is less than 1 kilogram in the first week. But after that, you want about 2 kilograms weight, okay? So remember this. First week, the action of spironolactone is slow. From second week onwards, you want them to lose about 2 kilograms and not more than 1 kilogram per day. If they have edema, and not more than 0.5 if they don't have edema. So if they're losing more than that, decrease diuretics. If they're losing less than 2 kilograms per week, increase diuretics, okay? Watch for side effects. Renal dysfunction, hyponatremia, hyperkalemia, gynecomastia. Do you check urine sodium here regularly? Good. Whom do you check it in? Akash? Do you want to sit up there? No, you're okay, you're okay.
So we checked in those patients to whom even we advise dietary restrictions, as well as those patients who are on diuretics.
But everyone, that means?
Sorry, sir?
That means everyone you're checking urine sodium?
Those whom we are expecting to be compliant to low sodium diet, and those whom we are trying to mobilize the fluid, grade 2 and more ascites.
Yeah, so it's generally when you've put them on diuretics, you've told them to decrease sodium, and it's not working. So anytime you're having difficulty in controlling ascites, check urine sodium. If they've been doing well for some time, and then it's not. So I gave you the answer already here first. So urine sodium more than 90, I told you should get rid of more than 90. They're losing weight. This is diuretic sensitive. And they adhere into sodium restriction. So what do you want to do here?
Do nothing, sir. Continue.
Good. No change. You're happy. They're losing weight, so urine sodium is high, don't change. Sodium less than 90, they're not losing weight. This means diuretic resistance. What do you want to do?
We'll increase the diuretics.
Increase diuretics. So it's very simple here. Now, urine excretion is more than 90, so they should have been losing weight, but they're not losing weight. So what does it mean?
Some more salt intake is there.
Correct. So that's how you check. So it's very simple how you decide whether they're taking sodium adequately or not, or whether you should increase. So some tips for you. Start 50 to 100, never please, no 400, okay? Count till 200 and then stop counting. So aldosterone antagonism takes about 4 to 5 days. Furosemide for tense ascites edema, Usually try and maintain a ratio of 100 to 40. Even though I say this, when people have a lot of lower limb edema, we may go to furosemide to 120 for a few days to get rid of that. Daily monitoring, weight loss, 500 grams per day, not more than that. 1 kilogram, not more than that if they have lower limb edema. Urine sodium excretion, 90 ml equivalent per day. Okay, some more tips. Be careful. Be careful in older patients. Be careful when they have underlying renal disease. So with increased creatinine levels, be careful about increasing dose of spironolactone quickly. Older patients, be very careful again because they get acute kidney injury. Pleural effusions, don't be aggressive with space, but also you don't need to mobilize. So patient with ascites, you need to get rid of a lot of fluid for them to feel better. Pleural effusions, 250 milliliters, if you get rid of, they can also feel better. Remember the thoracocentesis, how much are you removing? Typically not more than a liter. 500 is usually enough. So 250 milliliters is enough for pleural effusions. Don't get aggressive for pleural effusions. Eplerenone is more expensive, but I hear it's not so expensive here. And you can use that instead if they've got gynecomastia. So take home message, diuretics are very good, but use them carefully because side effects are common. Large volume paracentesis, quicker. Diuretics, you can use more widely, and of course, it's cheaper. Okay, so that's ascites. Now we're going to hepatic encephalopathy. Common, about half the patients with cirrhosis decompensated will ultimately get encephalopathy. You can divide it into covert and overt. Covert means it's hidden, only special testing. Overt encephalopathy, patients, increasing cause of hospitalization in these patients, in them. And remember, frail patients, no muscle, cannot take up ammonia, they have got worse encephalopathy than those with muscle. So the stages, 1 to 2 to 3 to 4. Okay, for the audience, mast cell cirrhosis, temperature 38, comes with encephalopathy, has ascites. What would you do now? Who wants to do a paracentesis? Why do you not want to do a paracentesis? What's that?
Sir, diagnostic paracentesis may be useful to rule out SBP as a cause
Very
of
good.
HE, but
Very
large
good.
volume paracentesis is not recommended.
Very good. So in this patient, it's looking like patient has fever, has got ascites, worsening encephalopathy, must be infection. So if you have worsening encephalopathy, so precipitated, two common things to think of is infection or a bleed. If they're not bleeding, likely infection. But also go over the medications. Maybe they've taken opiates, maybe the amount of lactulose you're taking is not good. If you take too much lactulose too, you get encephalopathy because of the electrolyte imbalance. They may be dehydrated, if the kidney is not working, all this will make the encephalopathy worse. Patients with alcohol-related liver disease may be drinking, liver disease getting worse and encephalopathic, and this non-precipitated. Remember, patients on proton pump inhibitors have a high risk of encephalopathy, have a high risk of SPP. So don't use PPIs unless you really have to. So another take-home message here. Your diagnosis is clinical. You don't need tests. Your diagnosis is clinical. So if you see altered mental status, you know the patient has liver disease. This is hepatic encephalopathy. No need to check ammonia. No need to do special testing. No need to get brain scans. Okay, it's a clinical diagnosis. Don't check ammonia. Why? because it causes more confusion in the mind of the patient, in the physician, than in the patients. So don't check ammonia. Nutrition, important. Don't keep their calories, keep their protein. Generally, vegetable protein is probably better, so don't restrict protein in these patients. Generally, the recommendation is small meals, liquid nutritional supplements, and especially the night supplements help these patients. Now let's come to lactulose. Lactulose take a large amount of that, and it traps ammonia and induces diarrhea. So that's the mechanism which lactulose acts. The problem is it's a carbohydrate which is broken to release carbon dioxide and hydrogen, which causes the bloating. That's what makes patients uncomfortable. So side effects, bloating, diarrhea you want, but maybe too much. Musculoskeletal, they get cramps. The serious ones are hypernatremia and hypokalemia, both of which can worsen hepatic encephalopathy. So this is a good study done by Jaz Bajaj. Looked at the quality of school rather than the quantity. So typically, teaching is 3 stools per day, but if 3 Bristol 1 is probably not good enough. So the simple rule is, if Bristol score is 5 or more, don't increase lactulose. And if it's already 5 to start off with, don't start lactulose. Okay, so that you have to do something else besides lactulose. Rifaximin, non-absorbable, seems to work well, has multiple uses in gastroenterology. Side effects are minimal, but I hear it is much more expensive in India than lactulose. So this is how we're going to treat encephalopathy. Stage 1 to 2, first episode, start lactulose. Also look for precipitating factors, which we've gone over. Infections and GI bleeding are going to be common. If they are improved, continue lactulose. So first episode, lactulose alone is enough. If they've not improved despite lactulose, you reevaluate your diagnosis. This is important. Maybe they've got something else. Do a better neurological evaluation, make sure they're stooling enough. If your diagnosis is correct, no other precipitants, adequate stools, that's when you add rifaximin or neomycin. And if they resolve on that, send them home on lactulose and rifaximin. But if they've not resolved, let's go to the next. So now they move to grade 3 or 4, or they've come with grade 3 or 4, look for precipitating events, start lactulose. Now 3 to 4, they cannot take by mouth, so you'll have to give it as an enema or start with a nasogastric tube. If they've got better, continue. The difference is if a patient has 3 to 4, send them home on a combination. If they've not improved, again, typically most patients should resolve with lactulose and rifaximin, and if they've not, reevaluate your diagnosis, look at stooling. They may be going to renal failure. Hyponatremia worsens encephalopathy. So look at that, try and treat precipitating events. Despite all this not working, add rifaximin. Still not working, what do you want to do, Akash? What are you thinking of here? Let's say MELD score is 12.
MELD is 12.
12. And you've tried rifaximin, tried lactulose, and still got encephalopathy.
Sir, it is not a definitely proven therapy, but we'll try with L-ornithine and L-aspartate.
Yesterday, someone told me it doesn't work. We don't have that, but you have to look for something else. So the patient does not have really bad liver disease, and yet is so encephalopathic. So remember I said you require a combination of bad liver function or a big shunt.
Yes, sir.
So anytime your score is below 12 or 15, and they're still not responding to treatment, then you need a cross-sectional image. Look for a shunt, and then you can embolize it. problem is if you don't have shunt, then it's very difficult to manage these patients. Okay, no shunt. Yes, Lola has been tried, zinc, branch change, but none of them are really very effective. Mars is effective, but it's very difficult to use. So if at the end of this it's not working, then you're in trouble. Okay, and if they recover, then send them home on lactulose and rifaximin. Okay, so take home messages. First case. Remember this case? Discuss importance of compliance with sodium. So remember, when patients accumulate ascites, the urine sodium is more than 90, most likely they're non-compliant with that. So take a message again, measure urine sodium in patients when the ascites is difficult to control. Safety precautions, give albumin if you're removing ascites. Usually give it within 6 hours to prevent circulatory dysfunction, and no INR or platelets are required. Hepatorenal syndrome, most common cause is low volume, so hypovolemia, currently classified as HRS-AKI and HRS-NAKI. So this classification is about 3 years old now. Urine sodium is not a criteria, but typically in hepatorenal it's less than 10. If you're getting a urine sodium more than 30 and they're not on diuretics, think that this is actually acute tubular necrosis in these patients. And like I told you before, there's vasodilatation systemically, not vasoconstriction. In the kidney, there is vasoconstriction. So marked arterial vasoconstriction in extrarenal circulation is not correct. And albumin and midodin, as you said, work, but it's not very good. Side effects of lactulose, hypokalemia, hypernatremia, abdominal bloating. Lactulose increase with type 4. So B, no encephalopathy. 7, don't worry. 2 has encephalopathy, but you already have 5. So lactulose is not going to work. Put them on rifaximin. 1 type 6, no encephalopathy. So varices, beta blockers or variceal ligation, both are effective, but there are some advantages of one over the other, so discuss with patients. If they bleed, use a combination. Combination doesn't work, use tips. Ascites, diuretics, albumin, tips, vasoconstrictors have different sites of action that you know from what I told you here. So take home message in the ascites, be careful about diuretics, especially in the elderly, because side effects and renal dysfunction are frequent. Daily weight and use urine sodium when they're not doing so well. Paracentesis is very safe and it's good for symptom relief. Encephalopathy, clinical diagnosis, no need of testing, don't use ammonia. Lactulose, if another take-home message, Bristol School 5. If that doesn't work, rifaximin. Okay, thank you. Questions now?
Yeah. So, what is the duration of treatment with lactulose and rifaximin after first episode of hepatic encephalopathy?
Yeah, so the question is, what is the duration of treatment of lactulose and rifaximin after the first episode?
And after encephalopathy?
So the first episode does not require rifaximin. So first episode has responded to lactulose, no need to add rifaximin. If they've not responded, then you add rifaximin. If it's grade 3 to 4 hospitalized, then you add on. The studies looked at 6 months. So if you ask me, does it work at 2 years? That we don't know, but you continue it indefinitely. Remember, if they have had stage 3 to 4 hepatic encephalopathy, we are not thinking that they'll live 10 years. They're either going to transplant or they're going to die before that. So that's the reason why these studies are done for 6 months and a year.
Sir, is there any role for serum ammonia? Like sometimes what happens in multi-specialty, we want to rule out liver as a
Does ammonia have any role at all? Yes, it has. So if you have an unclear cause of encephalopathy, nothing obvious, yes, it will be important. For one thing, you can rule out liver disease. If it is present, then you look for congenital shunts because you know they don't have features of liver disease otherwise. And rarely you will get patients with urea cycle disorders. And especially if you're looking at a patient who's in neurology, when you're on valproate, that precipitates urea cycle disorders. Ornithine decarboxylase deficiencies is more with dilantin sodium, with valproate than with dilantin sodium. Yes, so there is a role for undiagnosed encephalopathy.
Hello, sir. Sir, I just wanted to ask one question. In case of alcohol-related cirrhosis, presenting with altered sensorium has taken alcohol 4 to 5 days back. How to differentiate between a withdrawal and encephalopathy, and how the treatment will differ then?
So the question is, how do you differentiate between alcohol withdrawal and hepatic encephalopathy?
In a non-cirrhotic, alcoholic cirrhotic.
Correct, non-cirrhotic. So remember, alcohol withdrawal is a hyperstimulatory state. The reason they have to be given what's called the SIVA protocol, you have to give them sedatives round the clock, every 6 hours, is because they're so agitated. So that encephalopathy is more sedation, withdrawal is more agitation. They can even get seizures. So that's the best way to differentiate.
So will ammonia levels will be useful here?
So the ammonia level, so this is the problem. Ammonia definitely causes hepatic encephalopathy, but when it's in the brain. There are 4 organs which fight for ammonia. Okay, so when the gut produces ammonia, the liver, kidney, muscle, and the brain. So if the kidney is not taking it up and the liver is not taking it up, you have no muscle, it will go to the brain. So this is called the blood-brain ammonia axis, and that barrier is 8 to 1 to 4 to 1, so that what's in the blood may not be reaching the brain at all. So that is the problem with monitoring in the blood. Ammonia is important, but unfortunately we are not measuring it in the brain. That's where it's supposed to be measured.
Thank you, sir.
Thank you, Dr.
Vinod, you have a
Patrick,
question?
and my co-chairperson and panelist.
Sir, I have a question. I have one question. Sir, the finding that we have that the variceal bleed usually occurs during late evenings or early mornings. Why is it so? Is there any physiological or pathological mechanism, or because the sympathetic drive would be lower, the patient would be sleeping, so heart rate would be lower compared to the awakened time?
So it's a good question. So the question is, why do bleeding occur at night? So that is not clear, okay, because these are very difficult to actually study. So it is thought to be because of the sympathetic drive during REM sleep is what it's thought, but you can never prove that. And this thing of transmural pressure difference, so people have looked at where the barometric pressure in the atmosphere is measured most carefully is in airports. Airports have the record of what happens. So they've looked at emergency room bleeding, whether the bleed is more when the atmospheric pressure was less because the transmural pressure gradient. And maybe there is something like that, we don't know. But generally we don't know why it occurs at night. But do you find that more here at night?
Yes, sir, we do have that history.
Yeah, so that's the problem, it wakes us up at night.
And sir, one more thing, that every guideline, be it American or European, mentions the use of furosemide along with spironolactone, and torsemide has not been mentioned. Though people use it, it has not been mentioned. Is there anything associated with the pharmacokinetics of torsemide that it should not be used in decompensated CLD, in cirrhosis?
So the guidelines have been written from the West generally, and torsemide is much more expensive than furosemide. Also, furosemide has been around for much longer than torsemide. Cardiologists like torsemide. They use it very quickly because it's probably a better diuretic than furosemide. But the problem is we don't want a very good diuretic because if you mobilize fluid very rapidly, remember cardiology patients have lower limb edema. So when they get cardiac failure, you give them IV furosemide and they lose 5 kilograms. Patients with liver disease cannot. We know between 500 and 800, if they lose more than that, they go into renal failure. So that's why we don't want very strong. So more gentle the diuresis, better it is.
Thank you, sir. Thank you.
Good evening, sir. I am having two questions. First is, you told that the calorie which we have to give in hepatic ANCAF patient is 35 to 40 kilocalorie per kg. So is it like we have to give that much or restricted calorie, or it is the calorie which we have to give in excess? And my second question is, like rifaximin role is not so much in pediatric patient. Why is it so?
So there are two questions here. Restrictive. So we're talking about adults. So I'm not a pediatrician. So this is the adult. So rifaximin, they were always worried about starting a new drug in children. Second, hepatic encephalopathy is supposed to be easier to treat in children than in adults. Remember, the young brain does not get as much damage as the older brain. So hepatic encephalopathy is worse the older that you get. So you can correct me if I'm wrong, but pediatrics, there's less need for multiple drugs because they reverse from hepatic encephalopathy quickly. So it's difficult to get patients to do studies in them.
Yes, sir, but sometimes we have patients like they are in hepatic stage 3 and 4. So it's difficult for us to treat on the basic drugs. So rifaximin is not advised in such patients.
So I don't know what the drug authority has recommended here. It is not approved in children in the US. It's not because it is unsafe, it's because it's not been tried. It causes a little more renal insufficiency, but you can use neomycin. The only reason neomycin has not been that popular is because of the kidney dysfunction. Although it's a very good drug. Metronidazole is a good drug too.
Sir, that calorie one, I'm not clear about that.
So that is 35 to 50 is a lot for an adult. We are saying don't restrict the calories in them during that period, because otherwise muscle gets broken down and ammonia gets released.
Thank you, sir.
Thank you, sir. Thank you, respected dignitaries and Professor Kamath, sir, for this enlightening session. And I'm sure many of us would have got our concepts aligned properly. Now I would request Professor Dr. V.K. Dikshit, sir, to felicitate Dr. Professor Kamath, sir. And